गुड मॉर्निंग. शर्मा मॅडम आहेत. शर्मा मॅडम गुड मॉर्निंग.
गुड मॉर्निंग. गुड मॉर्निंग.
राजन सुप्रभात.
देशमुख सर गुड मॉर्निंग.
सुप्रभात.
गुड मॉर्निंग. सकाळी 3 वाजता
त्यांची मॉर्निंग सकाळीच होती. हॅलो दीपक. हा दीपक, आम्ही चालू करतोय. तर स्पीकर्सला जॉईन व्हायला सांगशील का? महाजनी मॅडम पहिले स्पीकर आहेत. महाजनी मॅडम पहिले स्पीकर आहेत. त्यांना जॉईन.
गुड मॉर्निंग सर. मी जॉईन झाले ऑलरेडी.
जॉईन झालेले आहेत.
आम्ही चालू करतोय. मॅडम जॉईन झालेले आहेत. दीपक मॅडम जॉईन झाले. गुड मॉर्निंग मॅडम. जॉईन झाल्या. ओके, थँक्यू.
पाटील सर गुड मॉर्निंग.
गुड मॉर्निंग पाटील सर.
गुड मॉर्निंग.
गुड मॉर्निंग सर.
गुड मॉर्निंग शीतल मॅडम.
गुड मॉर्निंग एव्हरीबडी.
मॅडम एक 2 मिनिटं फक्त डेलिगेट जॉईन होईल. एक 2-3 मिनिटांनी आपण चालू करूया.
काही प्रॉब्लेम नाही. यू टेक युअर ओन टाइम.
येस मॅम. येस.
गुड मॉर्निंग मॅडम. डॉक्टर देशमुख.
या देशमुख सर या.
मीनाक्षी येणार असेल तर तिथे बसेल ना
सर. कॉफी
सर. तोपर्यंत बसेल.
हो बसा की.
मीनाक्षी
काय प्रॉब्लेम नाही.
वेगळं सर आवाज बंद झालाय बरं. म्यूट केलंय.
हा आता येतोय.
ओके ओके.
ओके सर. ओके, थँक्यू.
गुड मॉर्निंग मॅडम. गुड मॉर्निंग.
गुड मॉर्निंग.
गुड मॉर्निंग.
स्ट्रेंथ आपली एवढी कमी आहे.
सांगा की.
4,900 ना. And he's going on increasing.
काय झालं दीपक? हा बोला. गुड मॉर्निंग. बोला ना. मी ऑलरेडी जॉईन झालेली आहे. हा ओके. रेडी आहे मी माझ्याकडून. थँक्यू.
लक्ष्याची मल्टिपल 30वी होती ना.
हो. We start. Aniket. Yeah, I think we should start now. Already almost 50 participants have. Huh? 49. हा हळूहळू चालू होतील मग सगळं. We'll start with it. Three minutes. Madam, we will start in another 2 minutes. Already 55 people have joined. Many more are joining, but we will start in another 2 minutes.
10 मिनिटांनी फोन करा ते चालूच करतात ना.
सांगितलं त्यांना 10 मिनिटांनी मारायला.
खबर नाही वाजले अजून. 9:07 झाले. 2:09 वाजून 10 मिनिटाला we will start.
Good morning, sir. Good morning, madam.
Good morning.
Morning.
पांडे सर आहे का?
हो. Should we start? Yes. Yes. I think we should start now. Myself, Dr. Sunil Ingre, Secretary IMA Pune. I welcome you all for this most awaited CME on spectrum of liver diseases and role of liver transplant, which was actually to be held physically in Sancheti Hall at IMA Pune. But due to this second wave of corona pandemic, we have actually made this change and we are taking it on a webinar. We all know that Sahyadri Hospital has done over 180 liver transplants, which is almost third highest in the country. And Sahyadri Hospital has also done not many pancreas and kidney transplants. Today we have the team of eminent speakers from Sahyadri Hospital to enlighten us about the spectrum of liver diseases and kidney diseases as well as pancreas and the role of transplant surgeries in all these diseases. We have Dr. Sheetal Mahajani, madam, who is a physician and looks after she's also a gastroenterologist and hepatologist. She looks after the team of Sahyadri Hospital for liver transplants. We have pediatrician Dr. Snehvardhan Pandey sir to talk about liver diseases and its management in children. We have anesthetist Dr. Manoj Raut sir, who will be speaking on the critically ill liver diseases and its management in ICU. We also have Dr. Kaurabi Zade, who is a radiologist. I am very happy to see her here. She is a radiologist. Till now, we all radiologists were only in the field of diagnosis, but the new team of radiologists is also coming up with interventional radiology and helping in the treatment part to the patients. Welcome, Kaurabi Zade, madam. We have Manoj Doshi, sir, a nephrologist, who will be speaking on kidney diseases along with liver diseases and its management. We have the most noted surgeons, Dr. Dinesh Jirpe sir and Bipin Vibhute sir, to talk about the actual process of transplant. And we also have Dr. Uday Phadke sir. We all know he is a very famous diabetologist, and he will be speaking on pancreas transplant. Pancreas transplant. So welcome you all for this very important CME, which is to be taken on a webinar. Now I request our newly elected president of IMA Pune, Dr. B.L. Deshmukh sir, to give his introductory speech. Thank you. Sir.
Good morning, everyone. Good morning, everyone. Today, this is my first CME in my tenure. Because of Corona, we are taking online webinar. I am sure you are all observing usual precautionary measures to fight Corona. Friends, I wish to tell you about IMA Pune branch activities for the medical fraternities. Our membership strength is 4,900. In Pune city, there are about 10,000 allopathic doctors. That means only 50% are IMA members. We should increase our IMA membership. Now I want to tell you about IMA academic activities. CMEs, webinars, IMA wings like IMA CGP, Association of Medical Specialties. Yearly conference like Multicon. Last year it was 30th year of Multicon. Medical Legal Cell is the unique specialty of IMA Pune branch. We have held and guided over 2,300 matters. In our team, Dr. Naurange, Dr. Meenakshi Deshpande, Dr. Jape are working hard for the same. Our medical legal team formulated consent form, which is accepted all over country. Another specialty of our branch is rush team. In case of violence or assault, our team rushes at site to help the victims, either medical, hospital or clinic. HBA activity. Our Hospital Board of India's sub-chapter has member of 150 hospital owners, which is the highest in Maharashtra. We have solved their day-to-day problems. Credit goes to Dr. Sanjay Patil, Chairman, and Dr. Padma Iyer. Organ Donation Committee, Dr. Arun Harbe and our past president is the chairman of this committee. Blood donation camps under the able guidance of Dr. Rajan Sancheti and Hilary Rodriguez. Last year we have collected more than 500 blood bottles. CPR training for the public like a policeman, rickshawala, firefighters, etc. IMA Social Security Scheme is like an insurance scheme. Beneficiaries get round about 9 lakhs and 64,000. Our Pune branch members are 940 only. Number should be increased. Our relations with the IMA Maharashtra. Our member, Dr. Sarda, represent MMC elected member. Dr. Avinash Bondwe, immediate past president of IMA Maharashtra State. Medical students book distribution for the poor, needy and scholar students from the BGMC. We distribute books for at least 10 students per year. Our extreme member Dr. Jain Naurange is the chairman of IMA Social Security Scheme. our relation with IMA HQ, our members bag following awards. Dr. Jain Naurange, co-chairman of Medical Legal Cell as well as Finance Committee and IMA Tribal Committee. Dr. Avinash Bhondwe, Director IMA CGP. Dr. Sanjay Patil, Action Committee HBI, Junior Doctors Network, Drugs and Medical Equipment. Dr. Sunil Ingre, Central Council Member for the Radiological Association. Arun Halbe, organ donations. Dr. Prakash Marathe, prevention of diabetic blindness and retinopathy of prematurity. Dr. Meenakshi Deshpande, standing committee member for safe motherhood. I would like to improve doctor-patient relation. Due to some misunderstanding between the patient and doctor, there are assault on the doctors, nurses, hospital staff, hospital properties, which needs to be improved. We are fighting for the mixopathy and assault on the doctors. Government is seriously thinking about these issues. About today's CME, along with Sahyadri Hospital, we have long association with the Sahyadri Hospital for the last 10 years. Hope this will continue in future years also. Sahyadri Hospital is doing fantastic work in liver and kidney, pancreas transplant. People are coming from this, coming from all over Maharashtra, not only Maharashtra, from other parts of the India also. आपण असे सीएमई वेबिनारच्या निमित्ताने वरचेवर भेटत जाऊ त्यावेळी मी माझे मनोगत व्यक्त करत जाईन. मी सुद्धा ही सीएमई ऐकण्यास तुमच्या इतकाच उत्सुक आहे. तर तुमचा फार वेळ न घेता मी इथेच थांबतो. धन्यवाद. लॉंग लिव्ह IMA. थँक्यू.
Thank you, Deshmukh sir. Now I request our secretary, Dr. Alka Shirsagar madam, to introduce our first speaker, Dr. Sheetal Mahajani madam. Alka madam, please introduce.
Yes. Good morning, all. I am Dr. Alka Shirsagar, secretary. I take this privilege to introduce our Dr. Sheetal Mahajani madam. She is the first speaker. And for her academic achievements, madam has done MD and DNB in medicine, and she has done DM and DNB in gastroenterology. She has achieved fellowship in liver transplantation medicine, King's College, London, UK. She has got 2 gold medals. One in MD examination held by Pune University in 1995, Hari Malini Joshi gold medal for securing first rank. And the second one, she's got SK Sama gold medal for first rank in DNB gastroenterology examination in 1998, ex-junior consultant in CMC Vellore. She has got her Govind Foundation's 1-year scholarship for the year 2002. She has fellowship in liver transplantation, King's College, London, UK, 2002-2003. She is a consultant in CMC Vellore. At present, she is director of transplant hepatology, gastroenterology, GI endoscopy, and hepatology, Sahyadri Hospitals. It is the busiest liver and multi-organ transplant in Maharashtra. She has got extensive experience in hepatology and liver transplant medicine over 17 years. She was instrumental and a part of first successful liver transplant program in Pune, Ruby Hall Clinic. She was also instrumental in starting liver transplant program in Sasun, Pune, and she is currently leading it. Thank you. Over to Dr. Sheetal Mahajani, madam. Thank you, madam.
I thank you very much, madam, for that wonderful. I will now, without wasting time, will proceed to the talk of today. And at the outset, I would like to thank IMA Pune for giving our hospital this opportunity of presenting our work. And I welcome you all on behalf of entire team of ours. And let us start with today's talk. Am I audible? And is my screen being shared? Okay. So I will be talking about spectrum of liver diseases and role of liver transplant in management of liver diseases. And I'll be giving the general overview rather than going into the nitty-gritty of every single detail of liver disease and the management. Now, why is this topic so important to us? We know that as per the 2014 consensus in our country, the deaths in India reached around 2,16,000, or that is 2.44% was only because of liver diseases. And that is why it is important to know about liver diseases and its further management. Now, we are talking about liver diseases. We must know how the liver diseases present to us. It can be acute liver failure, it can be chronic liver disease, or they can be subacute liver failure. This merely depends upon when the liver disease has started. That is nothing but the time frame involved in it. Now, certainly, we have heard the terms like decompensated chronic liver disease. When the liver disease exists for over longer time, that is the time when all the complications start appearing, and that is nothing but the decompensated liver disease. And to complicate the whole issue, we often see as physicians that liver is affected as a part of multisystemic involvement, whether it is malignancy or it is infection or it is cardiac disease and so on and so forth. And we have also seen liver affection in the current pandemic of COVID-19, which has really turned the whole world upside down. Now, coming to the spectrum of liver diseases, the commonest causes of liver disease in our country in adults is hepatitis A, B, C, D, and E. That is infective hepatitis, which is caused by the hepatotropic viruses. You can also have involvement of liver in the tropical illnesses like dengue, malaria, COVID, etc. Then there is something known as NAFL, which is nothing but a lifestyle liver disease, which is associated with the metabolic syndrome and which is becoming more and more common. This is nothing but the other extreme of fatty liver disease, which for a very long time we were ignoring. And now we know that it is the important cause of liver disease. Then we have autoimmune liver disease. Then we have cholestatic liver diseases like primary biliary cirrhosis, primary sclerosing cholangitis. Drug-induced liver diseases forms a major chunk of all the liver diseases in our country, and there are multiple drugs which affect the liver. We will come to that. And not so old but very important cause of liver disease remains is alcoholic liver disease, and that, mind you, is seen in females as well as males. Now, why I uttered females first is because of the changing lifestyles. We see that the urban women have started consuming alcohol, and it's not uncommon to see alcoholic liver disease even in women, which is very sad news, but a true news. Then vascular diseases of liver like Budd-Chiari, not to forget the liver cancers. There are certain cancers which are pertaining to the liver, and there are other cancers which can have metastasis in the liver. So both are important part of the spectrum of the entire liver diseases. Then we can't forget the metabolic liver diseases. Some of them, like, is very common in young adulthood, like such as Wilson's disease. And to complete the list, we have liver diseases in children, which my colleague Dr. Snehavardhan Pandey is going to highlight on. And then there are specific diseases which are common to the pregnant population. So that also we will touch upon as we proceed in this lecture. Now, come what may, whatever is the cause of chronic liver disease, the liver gets affected in multiple stages. In the first stage, there is fatty liver, then there is liver fibrosis, and then finally there is cirrhosis. Now, this cirrhosis is a dreadful complication of liver disease. It is called as end-stage liver disease. Why? Because once there is cirrhosis, then there are multiple problems which start appearing in times to come. Patients require multiple hospital admissions for increasing jaundice, ascites, GI bleed, early liver cancer, hepatopulmonary syndrome, renal affection because of liver, spontaneous bacterial peritonitis, and not last but not the least, they start getting very tired, and there is something known as sterility which sets in. And that's the reason why the treatment is essential of this end stage liver disease. Now, coming to the causes of liver disease, which I have already highlighted in our spectrum of liver diseases, some important causes for chronic liver disease in our country are hepatitis B and C cirrhosis, alcohol-related cirrhosis, NAFLD, autoimmune liver diseases, PBC, PHC, Wilson's, cryptogenic, and Budd-Chiari. On the cholestatic side, you have primary biliary cirrhosis, PHC, cystic fibrosis, and biliary atresia, which are seen in young adults. Now, coming to chronic liver disease, there are on one side the cardinal features of it and what investigations or battery of investigations we use to diagnose it. So, jaundice, ascites, encephalopathy, I believe, are the hallmark. In rare cases, you also get hepatopulmonary syndrome, hepatorenal syndrome, and portopulmonary syndrome. Generally, other than LFTs, gamma GT, PT-INR, which is the core investigations for any liver disease patient, one does autoantibody screen, immunoglobulins are measured, serum plasmin in young adults, ferritin measurement. In some rare instances, alpha-1 antitrypsin phenotype is also checked. Sonography remains the basic investigation. And then subsequently, CT scan, as it is called, three-phase or four-phase liver CT scan is the pathognomonic test to proceed with the further investigation and management. Liver biopsy, however, has very limited role in today's era because we have a lot of other investigations, non-invasive investigations, which tell us about the liver diseases. Now, in next 5-10 minutes, I'm going to touch upon every single liver disease, not more than one slide, just to give the introduction so that the transplant part of it is better understood. So we've already spoken about the hepatotropic viruses, out of which A and E are fecal-orally transmitted, and C and B are transmitted through blood. And C and B are the ones which cause chronic liver disease, cirrhosis, liver cancers, and hence they are dreadful infections to the liver. Now, D virus always requires coexistence of B. Now, other than these viruses, there are certain other viruses like Epstein-Barr, CMV, HSV, Parvo, which can cause liver disease, especially the acute presentation of liver diseases. And sometimes when you are clueless as to what is the cause of liver disease, it is important to run through this battery of investigations. And other systemic infections, as I mentioned earlier, dengue, malaria, rickettsia, leptospira, tuberculosis, systemic sepsis, schistosomiasis, which is not so common in our country, are known to affect the liver. And last, but the most dreaded infection of last year and this year is COVID-19, which also affects liver. But we have yet to see acute liver failure because of COVID. It is just the transaminitis and sometimes rise in the bilirubin is what is noted. Alcoholic liver disease is all we are all well versed with it. So just a couple of points which tell me that why it is alcoholic liver disease and not any other liver disease. Generally, these patients will have AST more than ALT and they have increased gamma GT and MCV in the hemogram. Fatty liver disease is nothing but self-inflicted disease, as we can say. It is because of our bad lifestyles. It is because of the metabolic syndrome, which is now seen all across our country. Earlier on, we used to think that diabetes is a disease of rest, but no, it is very much part and parcel of our disease spectrum in our country, and it is thanks to the truncal obesity, diabetes, hyperlipidemia, and it can be part of metabolic syndrome. It can also see coexist with hypothyroidism, and there are certain other diseases which can also have NASH and NAFLD in addition to the primary etiology like alcohol and other liver disease. They have in NAFLD one can see increase in transaminases, ALT more than AST. In the beginning, it can be mildly raised. One can have normal or minimally raised bilirubin to begin with. In absence of viral liver diseases, alcohol injury, negative autoantibodies, negative drug history, all that one is to remember. And there can be coexistence of more than 2 liver diseases. That also one needs to remember. Then common conditions associated insulin resistance as already depicted in diabetes, hyperlipidemia, obesity. Starvation and rapid weight loss is one of the common causes. In lean MAFLD, total parenteral nutrition can give rise to fatty liver. Certain drugs induce fatty liver quickly compared to the others. On histopath, you see steatosis, fat droplets in hepatocytes. Then one can see steatohepatitis in inflammatory cells. Then one can see fibrosis as the disease progresses, and ultimately cirrhosis. Mind you, this can take around 10 to 15 years for fatty liver to get evolved into liver cirrhosis. Drug induced, it is not at all uncommon. We know that in our country, all sorts of pathies, all sorts of herbal medicines are in vogue for liver diseases, and that is the reason why this is quite common. One can have hepatitis-like picture, cholestatic picture, or a mixed picture. Temporal relationship between the drug use and development of symptoms is essential. Discontinuation of offending agent reverts the symptoms. Monitoring hepatotoxicity appropriate for statins is important, and common medicines which can cause hepatotoxicity are INH and other antituberculous medicines, antiepileptics, antibiotics, so on and so forth. Autoimmune hepatitis, earlier we thought it's the disease again of the West, but we now know that in women population this is a common problem also. Sometimes in males also this is seen. Increased transaminases, cholestatic enzymes is a hallmark. Autoantibodies, smooth muscle antibody anemia positive. But one has to remember that one can have seronegative autoimmune hepatitis, wherein only IgG will be the marker which is raised, and all other antibodies may be negative. In that situation, one may require a liver biopsy, which can show portal inflammation and spill over into the lobule in a pattern known as interphase hepatitis of inflammatory cells. PBC, again in elderly women and men, it is seen. AMA is the subtype of autoantibody which is positive. Immunoglobulins, especially IgM, can be high. In people who have raised alkaline phosphatase, this is called as best screening test for years together, can be because of PBC. And mind you, PBC can give rise to intractable itching. PHC, people who have raised alkaline phosphatase, episodes of jaundice, pain, and fever, one must think about PHC. On histopathology, one can see onion skin fibrosis, but non-invasive method like MRCP can give rise, can show us the appearance of prune tree appearance, or as it is called, bleeding and multiple pictures. P-ANCA can be positive in such patients, and IgM hypergammaglobulinemia is seen. Wilson's disease is a disease of youngsters, but we have seen that early adulthood also can, one can see Wilson's disease. Stereoplasmin is the commonest screening test which is used. Slit lamp examination for KF ring is a must. Then in advanced workup, one can do 24-hour unit copper or hepatic copper concentration as noted on the liver biopsy. Hemochromatosis, one suspects when there is associated diabetes and typical complexion, that is very dark complexion, deep pigmentation, as it is called, and jaundice. Patient with hepatomegaly, one must think about hemochromatosis. Once in a while, we do see hemochromatosis in our country. Alpha-1 antitrypsin is rare, but one has to remember these causes once all the battery of investigations are exhausted, especially alpha-1 antitrypsin deficiency in people who have cystic fibrosis and pulmonary change. Then vascular diseases, very important, Budd-Chiari, acute chronic Budd-Chiari, will come to it little while later, and veno-occlusive disease are seen in some of the anti-malignancy medicines which can induce VOD in the liver. Pregnancy-induced liver disease is a whole spectrum, right from hyperemesis gravidarum to intrahepatic cholestasis to eclampsia, HELLP syndrome, and acute fatty liver of pregnancy. Now, HELLP and AFLP can be very detrimental to even the mother, and the outcome can be very adverse if not treated properly. Now, this is what is the specific medical management pertaining the cause of liver disease. Now, just one additional sentence here, that everybody should try and go to the root cause why the liver is affected. And that is important because you can offer treatment to certain liver diseases if they are diagnosed well in time. Like autoimmune liver diseases can be completely treated with either steroids or azathioprine. Hepatitis B and C, now we know they have wonderful antiviral treatment which is easy to deliver, and best results can be obtained, and the future liver transplantation can be prevented if these diseases are treated properly earlier. HCC, one can offer TACE, TARE, or RFA. Dr. Kaurav Sade will be talking about it later. Alcoholic liver disease, yes, in the stage where there is still fatty liver or fibrosis, to some extent it can be reverted if there is associated abstinence and if the complications of alcoholic liver disease are treated properly. And in certain small segment of ALD patients, one can use steroids to save the liver from transplant. And natural, yes, of course, all of us can, from the childhood, one can work towards it so that the liver will remain pristine all through our lives and will not require any further treatment. Wilson's, I've already mentioned, early diagnosis, penicillamine and zinc are quite effective in preventing chronic liver disease in Wilson's. PBC, ursodeoxycholic acid, one can treat for years together. PHC, there is single dominant switcher, one can do ERCP and prevent or postpone transplant. Hemochromatosis, Burkieri, as and when Burkieri presents in acute form, one can prevent the further liver disease by doing timely tips or dips. I'm sure Kauravi will highlight this in her talk. So coming to management, we have seen the specific management of chronic liver disease. There are certain complications of chronic liver disease which require highlight, that is ascites, proper use of diuretics, rational use of large volume paracentesis, use of plasma expanders, that's albumin, and salt restriction are the hallmark of treatment. Jaundice, one has to find out if there is extrahepatic obstruction, infection, or confounding factors for the jaundice that can be treated to reduce the jaundice. GI bleed, of course, every cirrhotic should have timely banding schedule or timely endoscopic schedule. As I tell all my juniors that we can't afford to have GI bleed with the background of CLD, and it can be completely prevented if you band the varices or take care of the varices properly and add them on beta blockers. Encephalopathy, lactulose, rifaximin diet, and motion frequency are the important parameters to control encephalopathy. FDB management and prophylaxis, proper antibiotics as and when needed. Somebody who has ascites, complains of abdominal pain and fever, FBP should be ruled out at that point itself. And prophylactic antibiotics after proper antibiotic course is the hallmark in preventing mortality because of SBP. HRS, Dr. Manoj is going to talk about it a little while later in a little bit detail. Albumin terlipressin is the treatment of choice. Patients in whom terlipressin cannot be used, one can use midodrine or noradrenaline. HPS, hepatopulmonary syndrome, transplant is the way out, and for portopulmonary syndrome, fluid restriction and sildenafil may be of use. Now, even though we know how to control the complications, once there is liver disease or cirrhosis, or once there is end-stage liver disease, as we call it, the final and the ultimate answer is liver transplant. Come what may, whether there is end-stage liver disease or failed liver because of acute liver failure or ACLF or end-stage chronic liver disease, the answer is liver transplant. Now, worldwide, the first transplant was carried out in 1963 in Colorado by one gentleman called Professor Starwell. But between 1963 and 70, they also struggled because of a lot of issues, and worldwide it got established as a treatment for end-stage liver disease from 1970 onwards. In India, the first transplant happened way back. There was a struggle decade, as I call it, for 10 years between 1990 and 2000. We are all witness to that. And the treatment got established since 2000. And now there are multiple centers all across the country. In the south, mostly disease donor plus living donor transplants happen. Maharashtra is quite ahead of all rest of the states of our country in performing transplants. In Pune alone, we have 14 transplant centers performing liver transplants. Sahyadri Hospital being the pioneer amidst all the liver transplanting hospitals in Maharashtra and in the country. We have 5 centers, and we have performed over 200 disease donor transplants and over 100 living donor transplants. Uh, to talk about transplants, as I said, has evolved. This cartoon shows how transplant was thought to be experimental surgery in years past decades, but it has evolved. People have done xenotransplants, that is, people have used animal livers for transplanting into humans. People, of course, in the experimental conditions, they were never successful. Artificial livers, where again animal livers or hepatocytes were used. Hepatocyte transplant has definite role and future ahead. First human transplant, as I said, was in 1963. First transplant in India in 1994. Stem cell therapy has only research potential, no definite treatment in liver diseases in our so far. Soft liver transplant and domino liver transplant is something which should be done more frequently so that the donor pool can be used effectively. And this is nothing but pioneer Dr. Thomas Tarzan, who died at the age of 90, and he showed really a ray of hope to patients of end-stage liver disease. And that science we follow all over the world today. First, so what's the scene in Pune? First, liver was retrieved in 2004, and that liver went to Hyderabad for transplantation, and the patient did very well. First liver transplant in Pune was in September 2012, but the first successful liver transplant happened on Jan 30, 2013, and that Mr. Dhavre, who is the first recipient of liver transplant in Pune, is still doing very well, and yes, very proud fact that he is living a very comfortable, healthy life. First liver and kidney happened in March 2013. Total liver transplants in Sahyadri group I already mentioned. We have crossed 200 in last 5 years. First adult living donor transplant happened in 2016. First liver transplant without blood products in March 2015. Survival rate is around 90% for CAD patients, and we also were successful in starting liver transplant program in Sachin Hospital, and that is matter of pride to all of us that we have made the difference to all the strata of the society as far as liver transplant is concerned, and nobody for the want of money will be denied liver transplant. First split liver transplant happened in 2019. One part of the liver came to Sanyadri for saving a life of a acute liver failure child who is doing very well. Now, so what is the changing paradigm? So we have seen in our lifetime that we struggled for transplants in Pune. We didn't have trained teams, we didn't have hospital support, we didn't have recipients, we are the recipients when they were donors, and we didn't have donors when they were recipients. Instruments, infrastructures, everything was a problem. Finances was a big problem. But now there is a changing paradigm. And in 2021, we now know that liver transplant is available to all, it is affordable to all, and it is accountable. Meaning thereby we have a successful liver transplant happening all across. It is not possible without a big team effort, and it is a huge team effort. Mind you, for one successful transplant, I may not be wrong if I say that more than 200 people work overnight to make one liver transplant successful. And you do require a very good team leader. And we are fortunate to have Dr. Vipin Vibhute leading this particular prestigious program of our hospitals, uh, uh, because of whose vision and wisdom we have come so far. Now, coming to the indications, all sorts of indications of end-stage liver disease, acute liver failure, and ACLFs, we have done transplants, and we have done successful transplants. When we talk about liver transplantation, we should consider the recipient issues, when to transplant, how to transplant, what are the steps in the actual transplantation assessment of a recipient, optimizing the recipient as I call, intradonoricity, which is the actual surgery, and post-operative management, which is the important mainstay of making a transplant successful. And we also require to guide these patients through their lives, and the life of the transplantation also is something which is very important. So we don't want situations like this as shown in this cartoon, that a person doesn't understand the importance of getting a new liver. If a person is going to celebrate that with a glass of drink, then these are not the patients who we want to transplant. We want to transplant patients who understand what is liver disease and what is the importance of saving their lives and getting the second inning in their lives. And when we talk about liver transplant, the quality of life issues are very critical, and uh, we must also see whether the life expectancy is going to be more than 1 year, which is predicted for that particular patient. So, why transplant should be offered, and what are the survival predictors? So, if we consider typically child cirrhotics, at the end of 1 year, only 20 to 30% will survive. As against, if you transplant them, the survival rate will go up to 85 to 90. And at 5 years, the survival for child cirrhotics is only 5%, as against 70% at 5 years after transplantation. And this is why the transplants is important. Timing is very important. We don't want to transplant people who have just near cirrhosis without any complications. And we don't want to transplant people who are in the ICU struggling on the ventilator with 4 inotropes and septic and having GI bleed, ongoing GI bleed, very high albumin. So we want to optimize these patients properly and we want to offer them transplant so that the survival after transplant is seamless and it adds value to their life and reduces the mortality, even morbidity after the transplant. So steps in referral for a general practitioner, if there is a chronic liver disease, it is better to refer to the transplant center earlier. One can counsel the families and rest of the job can be done by the transplant centers. Now indications wise, chronic liver disease and acute liver failure, both we can think about transplants. Chronic liver disease, I've already mentioned the list of chronic liver diseases which lead to transplantation and indications for acute liver failure. King's College criteria are widely used. I skipped the previous slide because paracetamol poisoning is not commonly seen in our country. Single INR value of more than 6.5 is the whole and sole criteria to take up acute liver failure patient for transplantation. If you don't do that, their mortality is very high. And coming up to contraindications of transplant, what are absolute contraindications and what are relative contraindications? Uncontrolled infections on the day of transplant is definitely absolute contraindication. Extrahepatic malignancies, advanced hepatic malignancies, active substance abuse, medical or non-compliance, and irreversible brain damage, especially for ALS patients, this is important, are the absolute contraindications. Very old or young individuals, especially for youngsters, it is the weight which is more important. Generally, all the transplant centers, they prefer the age of a child above 5 kilos. 2 days back, we have transplanted such a 6 kg, 6-month-old child, and he's doing well. Cross fingers, so far so good. Anatomic difficulties, there are severe extrahepatic disease are relative contraindications. One can optimize these patients and take it forward. So when we make the liver transplant recipient ready for transplant, what do? We work that patient up properly so that we know what is the cause of liver disease, we know what is the stage of the liver disease, what are the concomitant medical illnesses like IHG, renal, cervical, neurological. We see whether there are any other concomitant surgical problems and we perform that way of investigation so that this patient can safely go on the transplant table. When we are doing so, there are certain questions we need to answer before considering any patient for liver transplant. That is, what is the stage of the disease? What is the cause of the liver disease? Are there any comorbidities? Is there prothrombotic status? Is there associated liver cancer? And whether the portal vein is patent. Now, to our rescue are certain parameters, certain scores like PPT score or MELD score, which tell us about what is the predicted mortality while a patient is waiting on a transplant list. Psychological assessment is also very essential. A readiness for transplantation, lifelong immunosuppression issues and complications the patient should understand. Patient should comply with the treatment and most importantly should not go back to substance abuse. So psychiatrist opinion is of most important and financial considerations are also critical because one cannot do transplants without any financial aid. Now there are multiple institutions which come forward for financial help for liver transplant and so it has become very easy for the patients from all strata in the society. Now, what is the waiting list like? Once you have made the transplant patient ready from a medical point of view, one has to list these patients on the waiting list. For Pune region, Pune ZPCC is the organization which looks after the waiting list. One can have priority regards to the certain diseases on the waiting list. Now, ABO wise, ABO blood group wise, all these patients are listed. Assessment is done by MELD score and while on the waiting list, just putting somebody on the waiting list or preparing for transplant doesn't end our job. Our main job is also to maintain patients while they're waiting on the waiting list because the mortality of the waiting list can be very high to the tune of 60%, 70%, 50%. It varies from center to center It also varies from how aggressive the medical team optimize these patients. Then generally, if patients who are very sick, these blood investigations are repeated every 48 hours. Generally, the med score can be repeated every 7 days, 14 days, or 30 days. While, excuse me, I think there is a lot of background noise. Can we mute our mics, please? Can we mute our mics, please?
Hello, please mute yourself. Hello.
So while patients are waiting on the waiting list, we have to monitor patients for ascites, SBP, encephalopathy, GID, HRS, hepatopulmonary syndrome, cancers, etc. Nutrition is critically important. At least the patient should have 35 kilocalories per kilogram per day. Protein intake should be around 1 to 2 grams per day, and salt intake should be kept as low as 2 grams a day. So nutritional supplements, no proven benefit as far as the outcome, but then one has to have proper diet, which is well balanced with a lot of multivitamins and proteins is the key. Now, coming to the donor factors, donors can be either disease donors or one can have living donors. Disease donor law came in our country from 1994, but yet the donations are so far and few. That is why there are long waiting lists for organs, and it is a challenge actually. So, brain death law, declaration of brain death is legal. Maintenance before retrieval is very critical as far as the blood pressure, inotropic electrolytes, and liver ischemia is concerned. Generally, for liver can sustain cold ischemia of up to 10 to 12 hours. Storage of organ should be done properly. Organ transportation has to happen properly. When one is looking at the cadaveric donors, one also has to quickly see how healthy that liver is. As far as investigations are concerned, viral markers are a must. Some extra samples are always preserved if there is any issue. One can always run it through later. And the basic investigations like LFTs, RFTs, ABG, sodium content are critical. USG is always done to rule out fatty liver. Up to 30% of the fat can be accepted, but beyond that fat, it is detrimental to the recipient. Sometimes we do liver biopsies on these patients as well, and maintenance is very critical. To expand the donor pool, what is important to understand is living donor transplant, which is possible in case of liver, as liver regenerates once it is cut into two parts. Both the parts of the liver will regenerate. Now, this is such a beautiful science which has come to our health, but while doing so, one has to critically investigate the living donor so that there is no harm produced to the life of the living donor, and the liver which is coming out as the graft is useful for the recipient. So basically, basic investigations like ruling out diabetes or ruling out any infections like hepatitis B, C, HIV is done as the first stage. In the second stage, the liver fat content is measured by doing LAI, that is liver attenuation index. Anybody who has liver attenuation index of more than 5 plus 5 can be considered for living donation. Volumetry is a CT guided computerized equations which tell us about the volumes of liver, the right and left halves of the liver, before considering anybody for living donor transplantation. And then in advanced workup, other infections are ruled out, other fitness tests like cardiac fitness, etc. are done, MRCP is done, and lastly, committee clearance is required. Now, certain important points for living donors: healthy adult up to 55 years without any major comorbidities, without diabetes can donate liver. Major issues, morbidity and mortality. So to reduce that, all those investigations are what I mentioned are critical. ABO compatibility is seen. Organ to weight ratio GRWR of 0.8 is accepted. Fat attenuation is needed above 5. Anatomical variations have to be discussed in details with the surgeons, and for the donor, native liver should be at least 30 to 35% to save their life. Coming to the transplant surgery, I think Dr. Jip is going to speak to you about it in details, but everyone has to remember that two theaters are required always, one for the donor and one for the recipient. Generally, it is timed also like that so that the full estimate time is kept at its minimum. This is how the cirrhotic liver looks. It's quite ghastly as it looks. This is the explant of one of our patients, and this is the demarcation what is done before living donor transplantation, and this is the Mercedes-Benz of liver transplant, as it is called. Early intensive management is very critical. Ventilation, hemodynamics are the important things to manage and monitor in the first few hours post-transplant. Transfusions are seldom given post-liver transplant. Our thresholds are pretty low post-transplant because the anastomosis are fresh, and the surgeons are always very wary about the thrombosis which can happen in hepatic artery. And so everybody who's in the team is very careful about blood transfusions. Immunosuppressants are started inside the theater itself once the native liver comes out. Steroids are given, Solimidol is given at that point. Tacrolimus is started on the after 24 to 36 hours. Generally, the liver recipient hardly have pain unless they have very low MER scores, no ascites, and they are transplanted for the cancer. Sutures, care of abdominal drains is critical. So it's again a very big teamwork between the intensivists, the surgeons, and the liver physicians. Daily investigations are carried out, and sonography and Doppler is a hallmark. Immunosuppression, as I say, it is a science which has come to our help, but it is also an art. And one has to tailor-made immunosuppression for every patient's requirements. Generally, the protocols used are tacrolimus, prednisolone, and mycophenolate. In patients who have renal issues, one can think about everolimus, sirolimus, or prednisolone, or sometimes only mycophenolate and prednisolone, but that one can do later on. That is after 3 6 months of transplant. And in some patients, combinations of Evro and Tacro are also invoked. How is the life after transplant? Why so much fuss of transplant, such a difficult surgery, such a difficult post-operative course? It is done because the life of the transplant is something which is very fascinating. One can have second innings to their lives again. One can have such a big hope after transplantation. One can lead their lives, all their responsibilities as normally, as effectively as they could do it earlier. All they have to remember is to avoid infections, to resume all the activities beyond 3 months. Till then, we tell them to take proper care and the regular follow-ups with drug levels, and they have to be in touch with their liver transplanting team. Definitely, transplants improve the quality of life. They give you another life. It may not be wrong if I say so. One has to also remember about rehabilitation, and they should be encouraged to do their jobs beyond 3 months so that they can lead a normal, fruitful, meaningful life. This is a special trio. This is our first adult living donor transplant. This daughter of this gentleman was the reason why this transplant happened, because she was the force behind bringing her brother to the transplant table. He was very scared of transplant. He and his father didn't have good relations, but now they are a happy family, and they're all very happy, and they promote or they take this message into their rural areas that liver disease will be cured, and they have their meaningful lives now. What are do's and don'ts? One has to remember that medications are lifelong, especially immunosuppression. Blood tests are required pretty often in first year, subsequently every 3 months or 6 months. They cannot go back to substance abuse. They should be inculcated the importance of exercise. Weight gain should be prevented at all times, because post-transplant also the liver can have fatty liver disease, and if not slow, it can be even faster. So they have to remember that weight gain is not good for them, and they should restrict salt, because long-term immunosuppression, hypertension, diabetes are the long-term complications of these medicines. So if they are into regular exercise, good diet, and a little control on salt, they can lead lives as normal as other individuals, and they can lead meaningfully. So I will end my talk with this, with a pledge uh, for donating organs, and a request to come forward, help us for taking this organ donation drive at a larger level to another level, and for helping our society. I thank you all once again. If you have any questions, I'll be very happy to answer. Thank you.
Thank you, madam. Uh, Thank you for your elaborative lecture on spectrum of liver diseases, along with stages, variety of hepatitis, and specific acute liver cell damage management, and high risk cases, and final solution for liver diseases, that is liver transplant. And that also you have told about all indications, precautions, timing, criteria, contraindications, waiting list, and how it takes. It's a laborious job for a liver transplant, from starting till the patient comes out after 3 months, okay, without complication. So you are doing a very wonderful and great job. Thank you, madam. And now I request our president, Dr. B.L. Deshmukh, to felicitate you. Token of thanks.
Thank you, madam.
Thank you.
And this is
Uperne for you
from IMA.
and this is New Year's diary for you.
Thank you. Thank
Yeah.
you.
Sending it to you.
Thank you.
Thank you. Thank you. Now I hand over mic to Dr. Sunil Ingre for introduction of our next speaker, Dr. Snehawardhan Pandey.
Hello. After this very elaborative lecture on spectrum of liver diseases by Madam, now we have specific liver diseases in pediatric group. We have noted pediatrician Dr. Srivardhan Pandey to elaborate the pediatric liver diseases and its management. Dr. Srivardhan Pandey is MBBS, DCH and DNB pediatrics. He is DM pediatric hepatology. Dr. Srivardhan Pandey has completed his DM in pediatric hepatology from Institute of Liver and Biliary Sciences, New Delhi. This is the only institute in country that has a 3 years academic course in this field. He is first in the state of Maharashtra and fourth in the entire country to have completed this course. He is well trained to treat, manage children with liver, gallbladder and pancreatic diseases. He completed his graduation from Krishna Medical College, Karad. He did his DCH from LTMC Medical College, Sion, and he did his DNB from KEM Pune. He has been working in this field since last 3.5 years and has published various articles in many index journals. He has also presented many research papers in national and international conferences. His specialty is in pediatric liver, gallbladder and pancreatic diseases, pediatric liver tumors and endoscopic procedures. I request Dr. Srivardhan Pandey sir to take over. Yes, sir.
First of all, thank you very much for the warm introduction, sir. And I thank IMA Pune for giving me this opportunity to help us understand pediatric liver diseases and letting me give a talk on this topic. Sir, is my slide visible?
Yes, sir, it is visible. Yeah. Yes, sir, your slides are visible. You can go ahead.
So I'll just start by a brief introduction about what I will be covering in my talk. So we all know that pediatric diseases in children are very varied spectrum. So I'll be talking briefly about each diseases. What I'll be talking about these diseases just based upon how they present right from birth to the adult age group, how they usually evolve over time, and what are the different treatment modalities. So in children, you have different spectrum of pediatric liver diseases. Most of them are cholestatic liver diseases, which usually start very early in life, and followed by metabolic liver diseases, which I believe are the most common and the more dreaded of the liver diseases, followed by the infections. Then there are certain immune mediated disorders like autoimmune liver diseases and others like HLH. Then there are causes of more commonly which present with portal hypertension, but they are not cirrhotic, like extrahepatic portal vein obstruction, and followed by lastly malignancies involving the liver in children. So the most common disease that we come across in our routine pediatric practice, especially in children who are in their early infantile age group, are children who are having pale colored stools and with persistent hyperbilirubinemia, which is most often noticed when it is conjugated, and they have white colored stools. So this disease is called as biliary atresia. The problem is that the whole extrahepatic biliary apparatus is blocked congenitally, because of which there is accumulation of all the bile acids in the liver. There is alcoholic stools, and the child's natural history is such that it is a very rapidly progressive obstructive cholangiopathy leading to early liver cirrhosis. So the diagnosis is very simple. If one notices if the child has pale stools with high colored urine and the jaundice which is persisting beyond 14 days of life, one should think about such disorders. On the ultrasound, you see a characteristic atretic cord-like substance, which is called as a triangular cord sign. The liver biopsy is the most diagnostic, along with the intraoperative cholangiogram, which is can be used in selective cases. Now, most commonly, the surgeons would like to do a HIDA scan in all of these patients just to be doubly sure of the diagnosis. But I believe there is no role of HIDA scan in biliary atresia, especially if the children have pale colored stools. The HIDA will only indicate that there is no excretion of the bile salts in the stools. If there are stools are pale, there is no role of HIDA scan for diagnosing biliary atresia. It causes a loss of almost 7 days in delay in the diagnosis. And why these 7 days are very important is because this is a surgical emergency. The children need to undergo an urgent Kasai photointrostomy, because the entire success of the Kasai surgery depends on how early the surgery has been done. So within first 90 days, if the surgery has been done, the success rate is as high as 60% in countries which are doing a large number of Kasai surgeries. I agree that eventually these patients may need a liver transplant sometime in life, but a successful Kasai will help them to survive without a transplant for as long as 10 to 15 years. If the Kasai is not done timely, these children usually do not survive beyond 1.5 to 2 years of age. And biliary atresia, because of these diagnostic problems, it is the most common indication for liver transplant in children all over the world. Another similar disease, which is like biliary atresia, wherein they can have conjugated jaundice with pale or even pigmented stools, is a genetic disorder called as progressive familial intrahepatic cholestasis. We hear the term PFIC very commonly. So the problem here is that the biliary secretion is affected because of different defects in these canalicular proteins. And based on these different canalicular proteins, they have a very varied spectrum. So very commonly we find there is type 1, type 2, type 3 PFICs. They have to be differentiated from biliary atresia. Usually they have low GGT on their biochemical test. The problems with different types of PFICs are that type 1, besides involving the liver, it can also involve other organ systems like pancreas, the internal ear, and the intestine, causing diarrhea, hearing loss, recurrent pancreatitis, and even the respiratory tract, causing recurrent respiratory tract infections. Type 2 PFIC usually is also another severe disease which many a times mimics biliary atresia in its natural course. Type 3 PFIC is usually a milder disease wherein it has the overall natural history is such that the children usually present between 5 to 10 years of age, just with portal hypertension and with mild signs of cholestasis like mild pruritus and some hyperbilirubinemia, which has not been clearly investigated. The newer variants of PFIC are very dangerous compared to the other three. They have the tendency to develop even hepatocellular carcinoma in children as early as 6 months of age. And these are the patients who have to be timely diagnosed and have to be advised a timely liver transplant for better prognosis. Another similar disease is Alagille syndrome, which can be diagnosed by typical triangular faces. They have a typical prominent eyes, a long philtrum, and a pointed chin, known as the Alagille facies. They have a posterior embryotoxin in the eye. They have butterfly vertebrae and kidney and heart anomalies. And the diagnosis can be now confirmed by a genetic test. So how do we treat these cholestatic disorders? Firstly, you have to identify the cause. Biliary atresia, you have to identify the cause, diagnose it, and refer them for timely surgery. UDCA helps to basically help to mainly an antipruritic medication and helps to improve the biliary excretion. And these children are always deficient in fat soluble vitamins, and you need to supplement them with a good dose of fat soluble vitamins, which can be as high as 2 to 10 times compared to the normal children. They have to be supplemented with calcium, zinc, and other micronutrients. Usually these children are very in severe discomfort because of the pruritus. They have severe mutilation, abrasions, and injuries due to the pruritus. They need, for this, they usually need skin care with UDCA, cholestyramine, and other antipruritic measures. Most important thing in these cholestatic children is their nutrition. Most of them present with severe failure to thrive. And the problem because of the nutrition is that they need a caloric requirement which is at least twice or even thrice that what is needed in normal children. However, the appetite of the children is very poor because of a distended abdomen, presence of ascites, a large spleen, the encephalopathy, recurrent risk of infections, and the risk of aspiration. So in many children need just hospitalization just to improve their feeding. They have to be put in a nasogastric tube, and you literally have to feed them like you are giving them medications with timely dosing of every 2 hourly, 3 hourly, or even continuous feeding. They are advised to have high protein and high calorie density diets with medium chain triglycerides, and they are usually advised to have small frequent feeds or continuous NGD feedings in the hospital. Many of the patients' parents get trained for giving these nasogastric feedings, and they even continue it doing it at home for even months. For the surgical options, if the pruritus is refractory to medical management, these children need some surgical therapies like biliary diversion surgeries. So what is done is that directly all the bile acids that accumulate in the gallbladder are excreted directly through an external stoma, which is called an external biliary drainage. As you can see here, using a bowel loop directly from the gallbladder, it is through an external stroma, the bile acids are drained. Otherwise, this is definitely very effective compared to the internal biliary drainage, but the problem is the cosmetic part. The internal biliary drainage is usually less cosmetically bad, but the overall advantage is lost as the bowel adapts to the bile acid load, and there is high risk of failure of these surgeries. These surgeries have lost their importance over time and now more or less they are just considered for a bridge towards a transplant in selective patients who want to just tide away time considering the logistics for liver transplant, or who are severely symptomatic because of pruritus and need certain measures to control these severe symptoms. So the point is that when you see a infant or a newborn with persistent hyperbilirubinemia beyond 14 days of life, with alcoholic stools or high colored urine or signs of liver failure, he must be urgently referred for specific diagnosis and treatment without delay. Next, I will be talking about metabolic liver diseases, and I believe, including me, most of us know about Wilson's disease, but this section of our textbooks is the least read of during our post-graduation days. So there are different metabolic liver disorders. These are the most commonly that we think about in children. Galactosemia usually presents in an exclusively breastfed child with recurrent hypoglycemias, hemolysis, early newborn sepsis, and liver failure. Tyrosinemia as such can present at any age group, right from having liver failure, right from neonatal liver failure to acute and chronic liver failure, as well as in children, it can just present with refractory rickets. Now, hereditary fructose intolerance again is common in children who are just started post weaning. They are introduced to different fruits and fruit juices, and they typically develop symptoms after having fruit juices like vomiting and recurrent diarrhea and abdominal distension. Urea cycle defects usually presents with symptoms of hyperammonemia in children. And lastly, the storage disorders, which usually present with anicteric hepatomegaly, children just having a large liver without any signs of either liver failure or any complications of liver failure as such, but they have more issues with hypoglycemia, hyperuricemia, rickets related problems. So when do we consider metabolic liver disease in children, are when they have an underlying consanguinity with history of recurrent sibling deaths or fetal deaths, recurrent hypoglycemias, recurrent vomitings, diarrheas, any growth failure, any unexplained encephalopathy, or any anictoric hepatomegaly. So what are the treatment options in metabolic liver diseases? So this is just a broad classification trying to understand how metabolic liver diseases behave. So all metabolic liver diseases ultimately do not undergo cirrhosis. There are only a handpicked few of them who develop cirrhosis, like Wilson's, tyrosinemias, glycogen storage disorders type 4, who develop cirrhosis and will need liver transplant at some point of time if not timely diagnosed and treated. Whereas the non-cirrhotic metabolic liver disorders, they are the ones which may have either be well managed if timely diagnosed with specific nutritional therapy, or they may develop complications which are not just restricted to the liver but to other organ systems as well, and they need management depending upon that, either a liver transplant or a non-liver transplant related management. So these are the common disorders which at least have a specific nutritional management, and if timely diagnosed, these children can be well preserved with just nutritional management. Specific treatment options besides the nutrition is, like we all know, in Wilson's disease, I guess madam has also covered this point, they have specific chelation therapy for if they are started timely and if the patients follow up very well, they usually do very well throughout their childhood without developing complications of chronic liver disease. Antioxidants need to be supplemented in specific metabolic liver disorders like fatty acid oxidation defects, wherein these are depleted in the body because of the metabolic error and have to be supplemented so that the metabolism continues in a more preserved manner. There are certain ways in which the toxic substances in the metabolism can be reduced, and this form of therapy is called a substrate reduction therapy, like seen in Gaucher's disease, wherein they give certain substances which prevent the synthesis of the toxic substance, because of which there is damage to the liver and other extrahepatic organs. This drug is called as miglustat. Gene therapy is the new weapon that has come up, especially for Crigler-Najjar syndrome. There are specific enzyme replacement therapies for Gaucher's disease and glycogen storage disorder. And if nothing else works, obviously, lastly, we have the liver transplant. A new form of disorders are the ductal plate malformations, where choledochal cyst is one type of ductal plate malformation. And depending upon which part of the embryonic development, whether it involves the large ducts, or medium-sized ducts, or the smaller ducts, these disorders are classified as, can be named as choledochal cyst, Caroli's disease, polycystic liver disease, or congenital hepatic fibrosis. I'm not going into a lot of details in this, but these disorders usually present with either recurrent cholangitis or with persistent portal hypertension with varicose bleeding, hematemesis, and melena, requiring specific therapies depending on their complications. Infections are not new to our community. Hepatitis A, B, and hepatitis E are very common because of contaminated food and water and contaminated blood. Besides the hepatotropic viruses, even the non-hepatotropic viruses are common many a times when the hepatotropic viruses are negative. Liver abscesses are also very common in our side of the world, with most of them being pyogenic in children, followed by amoebic liver abscesses. Now, the problem with those infections is not acute hepatitis, but it is acute liver failure. And our side of the world, it is different because we have more of viruses and less of drugs, or less of indeterminate etiologies that is seen in the West. So hepatitis A, it contributes to almost 50% of all etiologies of acute liver failure in children in our side of the world. And hence, and it is the most dreaded complication of infective hepatitis. The management of acute liver failure is very demanding. It is multi-pronged and has to be done in a well-trained and well-coordinated intensive care unit. Raised intracranial pressure is the most devastating complication and the biggest cause of mortality in these patients. So they have to be managed with specific treatment and with specific protocols. I'm not going into details of them because I think Dr. Manoj will be covering a lot of it. The newer form of therapies are the extracorporeal therapies like plasma exchange and CRRT, And I believe there is enough literature now in to prove that these therapies are very good, specifically in patients who have need time so that they can be stabilized for liver transplant. They are not proven to have any therapeutic benefit in isolation, but they are definitely proven to have enough benefit as a bridge towards liver transplant. These children are very prone to infections, fluid electrolyte imbalances, and ultimately, if they are not responding to to medical management, they have to be timely listed and for a liver transplant. So I'm happy to be a part of this study that was done during my post-graduation days, wherein we did a study in children with specifically to hepatitis A related acute liver failure. And what we found that if the child had grade 3 or grade 4 encephalopathy with an INR of more than 3.1 and a jaundice to encephalopathy interval, that is, the child developed jaundice followed by encephalopathy with the interval between them is either more or equal to 10 days. Any two of these criteria, if it is present, it is a very significant predictor of mortality, and these children should be timely referred for liver transplant. About chronic hepatitis B and C, yes, they are very common in children as well, but they are a little better off in children because the acute hepatitis B usually do not need specific antivirals. They respond with just conservative management. The chronic hepatitis B also mostly do not need treatment because most of them are in the immunotolerant phase. But many of them, but there is much literature who say that children must be treated in even an immunotolerant phase. The chronic hepatitis C has has very good prognosis now, especially because of the development of the new directly acting antivirals, which are now very easily available in India as well. More important is to family screen these chronic hepatitis children so that the parents are timely diagnosed, the siblings are timely diagnosed and treated accordingly. What I was talking about non-cirrhotic portal hypertension, the three common causes are extrahepatic portal vein obstruction, which we call as EHPVOs. They are the most common cause of varicose bleed in children. And usually they present at around 5 years of age with the first episode of varicose bleed. Happy to say that these children most often do very well with just endoscopic management and with pharmacological treatment. However, after 30 to 40 years, they are known to develop complications of EHPBO like portal biliopathy and parenchymal extension. Many of these patients need shunt surgery for these complications. So NCPF and congenital hepatic fibrosis are other causes of non-cirrhotic portal hypertension, which usually present either very early in life, like in congenital hepatic fibrosis. It is associated with autosomal recessive polycystic kidney disease. Many of them present even in less than 2 years. Otherwise, most of them present in after 10 years of age. Like I mentioned before, these children need to be stabilized when they come with an acute varicose bleed. They have to be hemodynamically stabilized, given blood transfusions, started on terlipressin infusion. They go on long-term follow-up with recurrent endoscopic procedures and pharmacological therapies. And lastly, shunt surgeries if they do not respond to endoscopic and pharmacological therapies, especially if they have uncontrolled portal hypertension, they have significant growth failure, symptomatic hypersplenism, and portal biliopathy. Or if they are living in very far off places which do not have facilities of healthcare, considering the risk of mortality due to recurrent varicose bleed, they should be considered for shunt surgery. Now, Wilson's disease is not new. I'm not going very details in this because I guess madam has already covered them. Just want to highlight the fact that in children, more or less, they present with hepatic complications. In adults, they present more or less with neurological complications. They have a specific diagnostic score now called as the modified Leipzig score, where based on all the diagnostic tests that we have, they are scored. Excuse me. And they are diagnosed based on this score and treated accordingly. Autoimmune liver disease is again pretty common in children. They have varied presentation, right from infants presenting with acute liver failure, right till acute hepatitis, recurrent jaundice, acute on chronic liver failure, and even chronic liver disease. Like Wilson's, we also have a diagnostic criteria for autoimmune liver disease, just to be more accurate in their diagnosis. These children have to be timely diagnosed, especially when they present with the second episode of jaundice without any specific etiology. They have to be diagnosed with undergone tests for autoimmune liver disease. The liver biopsy is very suggestive and characteristic. They should have a detailed history with respect to their family history of any autoimmune liver diseases. These children do reasonably well until adulthood with long-term immunosuppression, but need regular follow-up for the same. About the liver malignancies, even in children, there are many benign as well as malignant liver tumors. Most common malignant tumor, especially in children between 6 months to 5 years, is hepatoblastoma. Happy to say that this disease is very well, it responds beautifully to chemotherapy as well as surgery, and hence it is very important to identify these patients timely and to treat them without any delay. Infantile hemangiomas also do reasonably well with just pharmacological therapy. However, the large hemangioendotheliomas, if they have underlying liver failure, they need some surgical management and even liver transplant in some cases. So most of the hepatoblastomas have underlying risk factors. The most importantly, they have a very low birth weight. So children whose birth weight is less than 1,000 grams have 15 times higher risk of developing hepatoblastomas. Unlike the adult tumors, for the hepatocellular carcinomas, in children, usually they do not have an underlying cirrhosis. They usually have underlying predisposing liver diseases, like right from storage disorders to chronic cholestatic liver diseases. These are all predisposing factors for pediatric hepatocellular carcinomas. The new age disorder now, which I feel everybody would agree, considering the restricted physical activities that the children face due to these lockdown issues, are the pediatric non-alcoholic fatty liver diseases. So we still don't have clear data as per for the Indian population, but this was a study in US that was almost 15 years back, where they found that children had a 10% prevalence of NAFLD with associated comorbidities like hypertension, dyslipidemia, and even insulin resistance. The worst part is that these children eventually develop cirrhosis just like in adults. Lastly, I would just take a couple of slides for pediatric liver transplant. So there are a lot of fears about pediatric liver transplant. Dr. Marjani ma'am has already covered a lot. Dr. Dinesh Zitpe and I guess Dr. Vipin Vibhuti sir will also be covering a lot. Just covering the pediatric aspects, it is more of the fears that stops us from referring patients and advising them liver transplant because of the cost, the long-term survival, and about the complication rate. But one must try to understand that our side of the world, especially in India, we are doing a lot of liver transplants and our results are comparable to the best centers in the world. I will not talk a lot in detail, but just wanted to show about these patients who are our own patients, and except this one where most of them just look at the difference post-transplant, how they are doing. I think the pictures explain what I wanted to say. Thank you.
Thank you, Dr. Srivardhan Pandey sir, for explaining us the causes of liver cirrhosis in children. You have elaborately covered all the cholestatic disorders, metabolic disorders, infective causes, as well as autoimmune diseases that eventually go on to cirrhosis. And in some cases, we need to do liver transplants in such babies, and they do very well after the liver transplant. That is what you have explained. Thank you very much. Now, I request our president, Dr. Balasaheb Deshmukh, to felicitate Dr. Srivardhan Pandey sir. Snevardhan Pandey sir.
Thank you, sir. This is bouquet for you.
My pleasure. Thank you.
Sir, this is I am a financial diary for you.
Very useful.
Thank you, sir.
Sir, we will be sending this diary to you in short time.
Yes, sir.
And this is I am a Uperne for you.
Thank you, sir. Thank you.
Thank you very much, sir. Thank you very much. Now I request Dr. Alka Shivsagar Madam to go ahead with the next lecture. She will introduce.
Thank you, Sunil. After seeing so many liver disease conditions in children, now there will be a lecture by Dr. Manoj Raut on critically ill liver patient management. So Dr. Manoj Raut, I will introduce him. He is a transplant anesthesiologist and liver intensive care specialist. He was born at Marathwada, Maharashtra, and went on to pursue his primary medical education MBBS at Government Medical College at Kolhapur. Then he took his postgraduate training in anesthesia at Pune. So he came to Pune and now he's settled in Pune, and he pursued his training in liver transplant anesthesia and intensive care at Sahyadri Hospital, Pune. So now over to Dr. Manoj Raut, sir. Sir, please.
Thanks, ma'am. Thank you. Whether it is visible or not?
Yes, sir. Yes, sir. Yes, sir.
Hello everybody. Thank you, Pune IMA, for giving me the opportunity to talk here. So my topic will be management of critically ill liver patients in ICU. I will going to talk on the basic management when patient came to the ICU with liver cirrhosis or ACLF. So the patient, many of the decompensated cirrhotic patients, there is a complex multisystem disorder which having a high mortality rate. So early intervention is the key to save the life of the patient. The prognosis of the patient is determined by the number of organ failure, the infection to the patient for which patient came to the ICU, and degree of liver dysfunction and any secondary illness like diabetes, hypertension, and CKD. The goal of the treatment are to prevent further deterioration of the patient, then reversing the precipitating cause causing all these things, and the supporting failing organs by our interventions. So basically, critical care management is a team approach which includes intensive care people, hepatologists, and surgical.
Full screen करा का please. Sorry to interrupt. Slide थोड़ी full screen करा ना. Slide.
Okay, just 1 minute. Is it okay, sir?
Okay. This is okay. This is perfectly fine, sir.
Yeah.
Yes.
Okay. Thank you. Yeah. So critical care management is a team approach with intensive care, hepatologists, surgical inputs also, and trained nursing staff. So the successful outcome will be depends upon the teamwork and not an individual person. So the hepatologist inputs basically needed for staging of the liver disease in active GI bleed for endoscopy, for HRS management in GI bleed protocols and transplant counseling. So surgeon is the key member and the leader of the team. You can say that surgeon is the main person. For transplant patients, the workup, fitness, and feasibility is to be checked by the surgeon, and post-operative issues like immunosuppression and surgical complications to be managed by the surgeon. So this is the ABC of the liver ICU, what we are doing in liver ICU for managing a patient with initial things like airway, breathing, circulation, drugs which are harmful for liver to be avoided, patient with encephalopathy to be taken care with early ventilations, restricted fluid strategy. GI bleed patients has to be managed very meticulously. Many of the patients are hypoglycemic, so we have to support with the sugars. Investigations and infection surveillance has to be a topmost priority. Renal replacement therapy whenever needed. And if patient need transplant, we have the med patient to understand the things and involve the surgical team. So basically decompensation with which patient admitted to the ICU are ascites, GI bleed, hepatorenal syndrome, spontaneous bacterial peritonitis, hepatic encephalopathy, jaundice, and coagulopathy. Our main discussion in this session mainly depends upon the basic things when patient come to the ICU, how to manage an initial assessment of the patient. So we will first talk about the airway and respiratory management of the patient. This is an initial chart by ASLD guidelines to manage a patient when come initial management of the patient. So there are some prognostic markers which, when patient admitted to the ICU, which shows that the mortality risk of the patient with liver specific like sodium MELD and CTP are there. General ICU scores like Apache score is a very good prognostic score to give mortality risk. There are some organ specific score for septic patients like SOFA and quick SOFA. And for ACLF patient, there is CLIF SOFA. So basically, patient with cirrhosis came to ICU with respiratory distress or breathless. There are some components like the cirrhotic patients are many of the times metabolic acidosis with respiratory alkalosis. So we have to manage that also. Patient with pleural effusion and hydrothorax, they are also came to ICU with distress, respiratory distress. Many patients in COVID era, like pulmonary infections will be there. And last but least is hepatopulmonary and portopulmonary system hypertension has to be managed. So patient with hepatic encephalopathy and active upper GI bleed are the topmost priority for intubation, as there are high chances of aspiration pneumonia. So we can reduce the complication with early timely intubation of the patient and ventilation. Many of the massive or moderate ascitic patient came to ICU with reduced thoracic compliances. There are chances of hydrothorax, hepatopulmonary syndrome patients, and volume overload patients came to ICU with respiratory distress. To manage this, the intubation for airway protection in these patients with GCS less than 8 and patient with active upper GI bleed, aggressive intubation has to be there to prevent aspiration. For ventilation of these patients, lung protective strategy has to be done with low tidal volume around 6 ml per kg, PEEP to be given to maintain oxygenation and plateau pressure to be less than 30 to prevent lung injury. Well compensated patients are usually hyperventilating. So there is hypocapnia and respiratory alkalosis. This has to be keep in mind. These patients basically there is metabolic acidosis. So whether to correct the unmeasured ions or lactic acidosis is a debating point. In hepatopulmonary syndrome, there is arterial hypoxemia. Hepatopulmonary syndrome is divided into three parts. It is mild, moderate, and severe. In all these patients, there is arterial hypoxemia. So there is no effective medical therapy exists for the hepatopulmonary syndrome. Liver transplant is the only current treatment available for the hepatopulmonary syndrome. Pleural effusion or hepatic hydrothorax. Many of the liver cirrhotic patients, around 15 to 20% patients have hepatic hydrothorax. Most of the times it is of right-sided, but left-sided is not uncommon. So hepatic hydrothorax has to be tapped whenever there is pulmonary and hemodynamic compromise. So thoracendosis is necessary in severe ventilatory compromised patients. Whenever possible, we should avoid the chest tube placement, as these patients are coagulopathic patients which can bleed and it causes more complications. So we come into sepsis in liver disease patients. Bacterial infection is more common in cirrhotic patients than general population because of their low immunity and they are in continuous inflammatory state. These patients are risk for numerous times of hospitalization, invasive procedures, ascitic tapping, so SBP, and prophylaxis for ascites like prophylaxis for SBP like quinolones. So infection in this patient is accompanied by markedly imbalanced cytokine response, which causes continuous or excessive inflammation in this patient, which prone them for infection. Sepsis is a common cause for ICU admission in patients and is associated very high mortality risk. The organ failure score has a better capacity to predict the mortality risk in liver patients. SOFA score is a very good score to find out the organ dysfunction, early organ dysfunction, and timely management of the patient. Cirrhotic patients often don't show any signs of infection, routine signs of infection like pyrexia, increased CRP. So we have to be aggressive to find out the cause of the infection, and appropriate antimicrobial therapy and source control is the main cornerstone of the sepsis treatment. Normally, follow the surviving sepsis guidelines for the management of sepsis. But in liver cirrhosis patient, the routine lactate level is high because of liver dysfunction. So in normal population, the lactate level is normally high. Septic shock in cirrhosis can be identified in the presence of hypotension, which requires vasopressor support, and lactate more than 2 millimole per liter, despite of adequate fluid resuscitation. As per the guidelines, the first hour bundle, which includes broad spectrum antibiotics, intravenous fluid administration, blood culture before giving antibiotics, measurement of lactate level, and inotropic vasopressor supports has to be started when patient came to the ICU with septic shock. Guidelines also suggest that fluid to be given as a balanced salt solution around 30 ml per kg over first 3 hours. But cirrhotic patients poorly respond to fluid, so albumin is a good choice to improve the mean arterial pressure. So our goal for the first hour resuscitation in a septic shock patient with cirrhotic, there is MAP around more than 65 mm of Hg. Urine output should be more than 0.5 ml per kg per hour. His CVP is around 8 to 12 mm of Hg, and central venous oxygen saturation should be more than 70%. So antibiotic therapy, when patient came from a community acquired infection, the initial antibiotic of choice should be of third generation cephalosporin. But many of these patients repeatedly have hospital admissions. So nosocomial infections in these patients have multi-resistant bacteria. So carbapenems and piperacillin tazobactam combination has to be started with along with the gram-positive cover. Hemoglobin threshold in these patients we keep around 7 to 8 gram per dl. Vasopressor of choice should be around, first is noradrenaline with or without vasopressin. Should be recommended to maintain the MAP. Chowdhury et al. Demonstrated that terlipressin is as effective as noradrenaline as a vasopressor, as it has an added benefit of reduction in the risk of variceal bleed. Dobutamine is recommended only in myocardial dysfunction patients. Otherwise, it is not recommended. Dopamine is usually not recommended that it can cause arrhythmias. Intravenous hydrocortisone did not show any mortality benefit in cirrhotic patients. Cirrhotic patients are usually in a vasoplegic state because of persistent high sympathetic drive and use of beta blockers for ascites, and they are more severe relative adrenal insufficiency. So regarding fluid managed part, uh, there is a 4-step approach to the fluid therapy. There should be first intravascular fluid assessment, then volume resuscitation, maintenance of the fluid status, and de-escalation of the fluid therapy whenever possible. So this is a chart which shows that volume shift in cirrhotic patients with portal causes portal hypertension, which because of portal hypertension, there is nitric oxide overproduction, which causes splanchnic and systemic arterial vasodilation, which causes reduce in cardiac output, which activates the renin-angiotensin system, sympathetic nervous system, and ADH release, which finally causes hepatorenal syndrome and ascitic formation. Because of this, there is intravascular volume depletion, but patient has ascites and pedal edema. So the assessment of the fluid status is mainly whether we keep the patient uh, well hydrated. If we keep patient inadequate fluid therapy, there should be hypotension, shock, and organ hypoperfusion and AKI. Where we give hyperaggressive fluid therapy, there will be impaired oxygenation, edematous state, patient already having ascites, hypertension, and organ congestions. So how you manage the fluid status of the patient? There are dynamic and static indices. Static indices are mainly mean arterial pressure and systemic venous pressure and pulmonary artery occlusion pressure. In dynamic thing, there should be pulse pressure variation, IVC collapsibility with 2D echo, esophageal Doppler and thoracic Doppler, transthoracic echo are good marker for dynamic fluid status of the patient. So fluid strategy to be given as a balanced salt solution like plasmalite is preferred over NS because NS causes high sodium, which causes hyperchloremic acidosis and renal failure. 5% albumin also a good fluid volume expander. Jellofusion can cause immune dysfunction, so it is better to avoid jellofusion. In patient with hypernatremia, normally gives 5% dextrose, but in lot of 5% dextrose also harmful thing. So avoid more 5% dextrose. So regarding nutrition part, it is also an important thing. Many of the patients are sarcopenic. So protein, carbohydrate, and lipid metabolism are affected in these patients. Second thing is there is decreased oral intake and improper absorption of the food and impaired digestion in this patient. So these patients have malabsorption and maldigestion and decreased oral intake. So there is a loss of protein, there is abnormal carbohydrate metabolism, lipid. All these causes stage of starvation or hypermetabolism. How we can see the nutritional status of the patient is by subjective global assessment, which has a 5 component: weight loss, change in dietary intake, presence of GI gastrointestinal symptoms, functional capacity of the patients, and metabolic demand of the patients. So recommendations are for compensated cirrhosis, there is 25 to 35 kilocalorie per gram per day of nutrition has to be there, with 1 to 1.2 gram per kg per day protein has to be given to the patient. These are European guidelines, which shows that 35 to 40 kilocalorie per kilogram per day calories and 1 to 1.5 gram per kg per day protein has to be supplemented to these patients to maintain their basic demands. Patients who are not reaching their caloric intake goals can be fed with nasoenteral tube. Patients which are not in which caloric intake goal by oral or enteral feed is not possible, in these patients parenteral route can be tried. Cirrhotic patients are there are small meals with evenly distributed throughout the day has to be given around 5 to 6 times a day. There is moderate sodium restrictions is the main to prevent ascites in these patients. Fluid restriction is not recommended until sodium decreases less than 120 millimole per liter. So these are the EASL guidelines for malnutrition in critically ill cirrhotic patients. Physiotherapy is a very important aspect in these patients, as these patients have a sedentary state or overall low physical activity. Their cardiorespiratory fitness is less, and many of the patients on mechanical ventilation and pressure areas, if patient is on sedentary state, causes bed sore. In cirrhotic patient, exercise studies have reported that there is improvement in muscle health, quality of life, fatigue, and reduction in hepatic venous portal gradient without adverse effect. So before starting physiotherapy in this patient, there should assess basic physical performance by short physical performance battery and single components such as gait speed. Thank you.
Sir, yeah.
Thank you, sir. Sir, thank you for your elaborative lecture, and really you have discussed very nicely the management workup and role of surgeon also, and it's a really a challengeable task. to manage such a critically ill patient. After all, it's a teamwork, sir. So you are told about the airway, breathing, bilirubin, circulation, drug, considering diet also, fluids, choice of fluids, investigations, nutrition, and at last the physiotherapy also. So, sir, it was really a very impressive lecture. So, we thank you, sir. And our Dr. V.L. Deshmukh, sir, our president, he will felicitate you.
Sir, this is bouquet for you.
Thank you,
Bouquet
sir.
Kindly
for you.
accept our token of thanks.
Thank you.
Thank
Thank you.
Sir, and this is our diary. You can keep on your table. It's a financial diary. Very nice, and all lectures are also there. In all topics are also discussed in nicely in this. You can have a very nice.
IMA Uparna for you. Thank you very much, sir.
Thank you, sir. Thank you very much, sir. Thank you.
Thank you.
Thank you. Now I'll hand over to Dr. Sunil Ingray for the next speaker introduction.
Our next speaker is radiologist Dr. Gauravi Zade. I am very happy to see a fellow radiologist. I being a radiologist, I am very happy to see a fellow radiologist taking part into treatment of the patients. Dr. Gauravi Zade has done MBBS, DMRD, and DNB. She has done fellowship in vascular and interventional radiology from Mumbai. She has done certification from European Board in Interventional Radiology. She is a vascular and interventional radiologist at Sahyadri Hospital, Pune. She has done her MBBS from GMC Nagpur and super specialization in vascular interventional radiology at Tata Memorial Hospital, Mumbai. She is trained in India and abroad. She got her European Board certification in vascular and interventional radiology. She has more than 5 years experience in vascular and image guided intervention. She has a vast variety of experience in peripheral and neurovascular interventions too. She is expertise in aortic aneurysms, varicose veins, peripheral arterial diseases, carotid stenting, aneurysm treatments, DVT treatment, and liver cancer treatments. She is a life member of IRIA, ISVIR. She is also a member of Cardiovascular and Interventional Radiology Society of Europe. And she is also a member of Society of Interventional Radiology. I welcome Gauravi Zade Madam for a talk on radiological interventions in liver diseases. Welcome. Over to you, Madam.
Thanks for your kind introduction, sir. Am I audible?
Yes, you are audible, ma'am.
My
Yes.
screen is seen because I am not able to see my screen.
Okay.
Yeah, is my screen visible?
Yes. The screen is also visible now.
Okay,
Yeah.
thank you very much, sir. So basically, I am a vascular and intervention radiologist working at Sahyadri Hospital, Pune. So I will be discussing about the spectrum of liver disease, which we as an intervention radiologist cover. So basically, just a minute. So if we talk about intervention, it can be very simple like this, or it can be very complex like this. So basically, patient selection and optimization is very important when we are dealing with liver interventions. So yeah. So the spectrum of diseases which we treat as an intervention radiologist are huge. It can be as simple as ascitic tapping, and it can be as complicated as Budd-Chiari syndrome. So like what we do in day in day out practices like ascitic tapping, liver biopsy, pictal drainages, biliary drainages, then liver cancers, which requires chemoembolization. Sometimes in emergency, we have to tackle the bleeders, then thrombosis, occlusion, stenosis, and Budd-Chiaris. These are the routine spectrum which we are treating at our institute. But the most important in all this treatment is the teamwork, because treating patient is one part, but it is the complete team organization, because a simple small procedure like ascitic tapping can lead to devastation if patient is not optimized well. So in all the patients, before starting the treatment, the optimization of treatment is patient is very important. We optimize the bleeding parameters in form of PT, INR. We see the platelet count. Hemoglobin should be optimized. What antiplatelets and anticoagulations patient is on. All this needs to be monitored, and then only we plan any procedure. If because of underlying liver disease some parameters cannot be corrected, then it needs to be taken off well. For example, if we have to do a biopsy of a patient whose platelet count is 10,000, still we can do that, but that requires a complete teamwork. Like if I am doing a procedure, then we do coiling of that track so that patient should not bleed. Then we monitor the patient for drop in if there is any drop in hemoglobin, if there is any active bleeding, and if any emergency is required, we are prepared for that. If there is many massive ascites, still we require liver biopsy for patients. So in such cases, we go ahead with transjugular liver biopsy. So these are the ways out if patient cannot be optimized, but it should be planned in a proper way, because all these CLD patients are very high risk, and even a simple ascitic tapping can lead to massive hemoperitoneum. We have seen this kind of cases. So we follow all the protocols before going ahead with the treatment part. So going in detail with a few procedures, for example, biliary drainage procedures. This we are doing routinely, and the indications can be cholangitis, raised bilirubin due to obstruction. So I'm just giving an example here. This is a patient with malignant hilar carcinoma. So we can see on the image that both right and left biliary system is completely obstructed. So most of the time in such cases, if by endoscopy it is not possible, then we go ahead percutaneously and do the drainage procedure. And then this kind of stentings can also be done percutaneously, and then patient can be taken up for chemotherapy. So these are the combined team approach. Like if this is not done, then everything can be done in a different way. For example, this is a case of percutaneous cholecystostomy. If this patient was in sepsis, so obviously surgery could not be done because of sepsis, but at the same time, this infection needs to come out. So in this case, what we did is a percutaneous gallbladder drainage. So once the patient was stabilized, after 2 months, patient was taken up for surgery. So these are can be the bridge procedure for the main treatment. Speaking in detail about liver cancer, liver gas intervention radiologist, as an intervention radiologist, we play a role in management of liver cancer. Most of the time, the treatment plan is decided by the multidisciplinary tumor board. Decision is taken on the basis of underlying liver disease. If patient is already cirrhotic and child's B, so obviously, sometimes the surgery, considering the liver condition and patient's general condition, ECOG status, surgery is not a option in such cases. So in such cases, we are pitched in, and then we take ahead with the treatment part in form of chemoembolization, RFA, and radioembolization. Sometimes the patient is a candidate for future liver transplant, but in such cases, this type of treatments are taken as a breach to liver transplant, because by the time if patient is ready for transplant, this liver cancer should not spread. So this kind of procedures act as a breach to liver transplant, and sometimes this procedure are planned as with a palliative intent to increase the lifespan. So going to treatment options, we have multiple treatment options. All these treatment options are minimally invasive, like radiofrequency ablation. What radiofrequency ablation is, we directly target the tumor under image guidance and we ablate it, getting an adequate margin. Then transarterial chemoembolization. What transarterial chemoembolization is, we go selectively to the artery feeding the tumor. Then we inject the chemotherapy drug there and block that artery. So the chemotherapy, it helps in two ways. First, the chemotherapy drug destroys the tumor cells, and also blocking the artery causes the hypoxia and ischemia. Then transarterial radioembolization. These are also very successful treatment options in the advanced liver cancer. So going to case, this is a case of very small HCC detected incidentally in the patient. Okay, so this was detected on MRI. So we can see this nice enhancing tumor. So the data is very well supportive in this. So what we do in such cases, it's a very small tumor. So what we did is we went ahead with radio frequency ablation. You can see this electrode going there and burning that tumor. So this is a very minimally invasive option. Treatment is with curative and treatment plan is with curative intent, because once the tumor is controlled, it is we get a good margin. Less likely it is going to come at the same size side, because the size is very small. Okay. So coming to next case, this is a case of HCC. We can see this HCC arterially enhancing large well encapsulated, since it was a central location. So this patient was also referred for chemoembolization, since this was a slightly larger tumor. This was a 5 centimeter tumor. So this patient was not a candidate for radiofrequency ablation. We went ahead with transarterial chemoembolization, and these are the final result. We could achieve complete necrosis and there was no growth even after a long-term follow-up. So these treatments can be done with a curative intent also. This is another case where we recently did very huge tumor. It was almost 16 centimeter large tumor. Like if with such a large tumor, this treatment we planned as a bridge to surgery, because with such a large tumor, even if we plan surgery, if it metastatizes in next 1 month, then the treatment is of like if it is metastasized, such an aggressive surgery is not going to help. So chemoembolization helps in decreasing the size of the lesion, because such a large tumor we cannot treat with a curative intent. Obviously, ultimately this patient is going to require surgery, but with chemoembolization we decrease the size of the tumor, we decreased the tumor burden, and at the same time we got the time to understand the biology of the disease, whether it is very highly fast growing, it is metastatizing fast, and then the surgery was planned for this patient. So in different setups, like last 3 cases I have shown, last 2 cases what I have shown, the treatment was with curative intent. In this patient, the treatment was as a bridge to surgery. So all these decisions are taken with multidisciplinary team, the surgeons, the hepatologist, the oncologist, every one of us sit together and take a decision what is best for the patient. Ultimately, this patient went for surgery. Now this is as I discussed earlier, the treatment can be palliative, but if we can treat the patient with good palliation, it is always better. This is a case for HCC with portal vein thrombosis. Like if we have a patient with HCC with portal vein thrombosis, the lifespan, as we all know, is very less. But transarterial radioembolization is a very minimally invasive and very nice treatment if patient liver function is good, patient's child status is good. We control the growth of the tumor. We are not saying that we are curating the disease, but at the same time we are controlling the goal. This is 2 years follow-up scan. The portal vein thrombus is stabilized there only. There is no further growth. It may grow after 3 to 4 years, but at least we have given a good palliation for this patient. And sometimes this patient turn up for surgery. It's not like that patient may not turn up for surgery. If such a stabilized tumor, may further go for surgery. So transarterial radioembolization can be treated as a curative intent, and also as a bridge for liver transplant, and also as a bridge for surgery. So it has a very good control on tumor, and it stops the growth of tumor, and at the same time the metastasis and further growth is avoided. As an intervention radiologist, we have to be on our toes because sometimes the bleeding, RTAs are like we have to treat this if the patients are bleeding and cannot be controlled by any other ways. So I will share this case of recently we did. He was a hemophilic. He had RTA and he had liver and kidney laceration on imaging. So immediately the patient was under hypotension and he was immediately operated, and liver laceration and renal laceration was treated. But since he was hemophilic, he was high risk for bleeding. He was still oozing from the drain. So in such cases, doing resurgery is very difficult. So in such cases, we as an intervention radiologist come in picture. Sorry for this image. I couldn't get very nice image of this case. So the purpose of showing this image is like we selectively go into the feeder and just block it off. So it's like it's a small little prick, and navigating into that artery and blocking that artery is easier in such situations rather than doing a resurgery. So other group of diseases which we as an intervention radiologist treat is the thrombosis and occlusions. Like we do routinely thrombectomy and stenting for stenosis. So I will just discuss case wise because it is case wise presentation becomes easy to understand. So this is a case of hepatic vein stenosis. This gentleman, the liver functions were good. There was no cirrhosis, and only symptom he was having was ascites. So hepatic vein stenosis was diagnosed on ultrasound and CT. So this is an invasive hemogram. We can see a significant stenosis in the hepatic vein. Okay. So we did first balloon angioplasty. We can see how the pressure gradient, how the pressure gradient was. So finally, this was treated with hepatic vein stenting, and the stenosis has gone, and we could get a good result, and ultimately the ascites was also gone. So another case, this is a case of Budd-Chiari syndrome. On imaging, hepatic veins were not seen. Patient had hepatomegaly and ascites. So I will just show how this is done. So from IVC, a track is created from liver to portal vein. This is the most difficult part of this procedure. Like we are blind in terms of where the track is going. Once we are in the portal vein, this track is created and dilated. So these are the final results. The stent is deployed across the across the track, and these are the final results. This helps in diverting the blood from portal vein to IVC so that the liver congestion is decreased. So this is another complex case which we treated. This is very rare. We have not seen much, but this is very rare situation that after 1 year patient presented with portal vein stenosis. Okay. So percutaneously we directly went into portal vein. This image is very nicely showing the stenosis. You can see the clips post surgery. So this stenosis was very significant. There was a significant pressure gradient across it. So it was treated with stent, and ultimately the symptoms and raised liver enzymes resolved. Okay. This is another rare case which we rarely come across. Basically, chylous ascites and chylothorax. This comes once in a while. So this patient underwent abdominal surgery and developed chylous ascites. This patient was then referred to us, and lymphangiography was done. So you can see this. This is a contrast leaking from that lymphocyte. So this is a lymphangiography image. You can see how this lymphatics is taking this dye, the lipidol which we use in this, and this dye is leaking here. So once we know from where the leak is, we embolize that with glue, and in this patient within 15-20 days, the leak was stopped and patient was cured of chylous ascites. So chylothorax and chylocystitis comes in between. They can be spontaneous, they can be post-abdominal trauma, and it can be after major abdominal surgery. So lymphangiography is the diagnostic as well as some treatment part we can do. We do embolize this lymphatics wherever they live. Conclusion of my entire presentation is, as an intervention radiology, we can offer a very minimally invasive image guided treatment with a small recovery time. But the most important thing is selection of patient, and which comes with a excellent team and teamwork. Before going ahead with any treatment, it is a routine culture in our practice. We all sit together, decide a plan, and then execution, like my teacher used to say, execution is not very important, it's the planning which is very important. If your planning is wrong, the execution will always go wrong. So it's the teamwork which is very important to decide the treatment. Even for a simple biopsy also, we decide what is to be done, what will be the next plan, and then only we went ahead. All complicated procedures we are doing very routinely after a group discussion, and then we are executing in patient. Thank you very much. Sir, any questions I can answer?
Hello.
Any questions for me? I can answer that.
There are no questions in the chat box. I request the delegates, if you have any questions, you can put in the chat box. I'll be happy to ask it. Anyways, thank you very much. Thank you, Kauravi madam, to show very good cases. And although it looks very simple, I know it's very difficult to do these procedures percutaneously, and you are definitely doing a commendable job in Sahyadri Hospital by helping all these surgeons by your techniques of interventional radiology. Thank you very much, madam. I request our President B.L. Deshmukh sir to felicitate you. Sir, please.
Madam, this is bouquet for you.
Thank you, sir.
Madam, this is a IMA financial diary which we will be sending you across to your hospital. Thank you very much for accepting it.
And madam, this is token of thanks from IMA Uparna.
Thank you, ma'am. Thank you very much.
Okay, thank you, madam. Next.
Yes. Thank you, madam. Now I'll, after discussing, madam, this very rare radiological, very rare these liver disease problems. You have done very wonderful job in radiological intervention. Now we'll go to our next speaker, nephrology speaker, Dr. Manan Doshi, who will discuss spectrum of kidney diseases in patients with liver failure and their management. Dr. Manan Doshi is a well-known best nephrologist in Pune. He is working as a consultant nephrologist in the nephrology department at Sahyadri Hospital, Pune. He is an expert in diagnosing and treating kidney disorders such as amyloidosis, diabetic kidney disorder, electrolyte disorders, glomerulonephritis, hypertension, kidney diseases. Dr. Manan Doshi did his MBBS from Jawaharlal Nehru Medical College and MD in General Medicine from MP Shah Medical College, Jamnagar, and DNB Nephrology from Apollo Hospitals, Chennai. He is a bright student and also received a gold medal in medicine in MP Shah Medical College, Jamnagar. Before joining Sahyadri Hospital, Dr. Doshi was an associate nephrologist at Apollo Hospitals, Chennai, and he was also an assistant professor, senior resident with the Department of Medicine at MP Shah Medical College, Jamnagar. Dr. Doshi has successfully conducted a unique thesis on comparison of hemodynamics and hydration status in patients with individual dialysate sodium versus uniform dialysate sodium as a part of the DNB curriculum. Bravo, sir. He was also a part of a publication in membranous nephropathy because of chronic mercury poisoning from traditional Indian medicines. Report of 5 cases. Thank you, sir. You have done a wonderful job. Now over to Dr. Manan Doshi. Thank you, sir.
Thank you for the kind introduction. Am I audible?
Yes, sir. Yes, sir.
Okay, I'll just share my screen.
Yes, sir.
Is the screen visible too?
Yes, sir. Yes, sir.
So thanks for the kind introduction, and I will thank IMA for giving me this opportunity to speak today. From morning, we are just talking about liver, liver, liver. So we'll take a breather with liver and just talk about some other diseases associated with liver disease, especially which have a outcome, which bear an prognostic importance in the outcomes in patients with liver disease. So today I'm going to talk about cirrhosis, the pathophysiology in relation to kidney, the electrolyte and acid-base abnormalities associated with patients with end-stage liver disease, and conundrum of hepatorenal syndrome and AKI, dialysis in patients with ECL, end-stage liver disease, and about combined liver-kidney transplantation. So, as we all know, cirrhosis represents a very late stage of progressive hepatic fibrosis, and it is susceptible to variety of complications. It approximately accounts for 50,000 deaths and is the 8th leading cause of death in the United States. And most of the complications that are associated with cirrhosis are due to portal hypertension, which is the increased pressure in portal venous system. The complication of portal hypertension could be ascites, it could be hepatic encephalopathy, it could be variceal hemorrhage, it could be spontaneous bacterial peritonitis, portal hypertensive gastropathy, cirrhotic cardiomyopathy, hepatopulmonary syndrome, portopulmonary hypertension. But we are here to talk about hepatorenal syndrome and complications associated with kidneys and electrolyte imbalances. So let's dive into the pathophysiology. So this is the chart which we might see frequently today in my presentation because everything is related to this. So when patient has advanced cirrhosis, there is increased intrahepatic resistance. That causes portal hypertension. Now, portal hypertension causes endothelial release of vasodilator mediators like nitric oxide, carbon monoxide, and endocannabinoids. Also, cirrhosis is associated with bacterial translocations and pathogen-associated molecular patterns and damage-associated molecular patterns with associated with activation of innate immunity and inflammatory response that leads to various inflammatory mediators. So these vasodilators in combination with various inflammatory mediators leads to splanchnic arterial vasodilatation. Now, this vasodilatation causes decreased peripheral vascular resistance. Hence, there is effective circulatory volume is less. Now, along with cirrhosis, there is also cirrhotic cardiomyopathy, which causes reduction in cardiac output. That also contributes to this decrease in effective arterial volume. Now, this is perceived by the kidney as low volume in the body, and hence various neurohormonal systems are activated, like renin, angiotensin, aldosterone system, sympathetic nervous system, AVP release is activated. Now, what it does is it avidly absorbs salt and water and tries to increase the intravascular volume at the cost of renal vasoconstriction. Now, this renal vasoconstriction causes decrease in GFR. This decrease in GFR has autoregulation mechanism like prostaglandins, but that can autoregulate only till an extent, after which the kidney injury persists. Now, first we'll talk about electrolyte abnormalities in end-stage liver disease. It is common. It can be because of disease per se, or it can be because of therapeutic interventions. Like we commonly use diuretics in patients with cirrhosis. We commonly use lactulose for facilitating bowel motion movement in patients with cirrhosis. And these all can cause electrolyte abnormalities. So there's an interplay of multiple opposing factors in fluid homeostasis, and hence the picture is very dynamic. And electrolytes do have an important role in patients with end-stage liver disease because hyponatremia parallels liver disease progression and is a short-term indicator of poor prognosis. Also, various electrolyte abnormalities like hyponatremia, hypokalemia, metabolic alkalosis can precipitate hepatic encephalopathy. So how does hyponatremia occur? So coming back to the chart again. So patients with liver cirrhosis have hypoalbuminemia, hence reduced oncotic pressure. Also, when there is splanchnic arterial vasodilation, there is increased hydrostatic pressure. And going back to Starling's law, it will propagate ascites. And when there is activation of renin, angiotensin, aldosterone system along with arginine, vasopressin, there will be salt and water retention. Albeit water retention will be much more than the salt retention, and that would cause dilutional hyponatremia. Now, incidence depends on definition that we use to define hyponatremia. If we use the universal definition that sodium less than 135, the incidence is 50%. But if we use the definition of sodium less than 130, the incidence of hyponatremia is 1 in 5. Most commonly, the type of hyponatremia that we see in patients with cirrhosis is hypotonic hypervolumic category. We'll discuss about that in a while. Hyponatremia has multiple associations in patients with end-stage liver disease. It is associated with refractory ascites, spontaneous bacterial peritonitis, hepatorenal syndrome. It is a trigger for hepatic encephalopathy, and also, most importantly, it is an independent mortality predictor. Now, this is the common stepwise approach to hyponatremia that we always talk about. So the first step is to rule out non-hypotonic hyponatremia, that is pseudo-hyponatremia. So this is common in method that is indirect ion selective method if we use to measure the sodium, because that includes various dilution methods. So if patient has increased globulins, like in patients with autoimmune hepatitis, or in alcoholics where there is increase in immunoglobulin A, or HCV patients where there can be cryoglobulinemia, or fatty liver disease where there can be hypertriglyceridemia. So these all can falsely show low sodium. So this can be excluded by using a direct ion selective electrode to check the sodium, or you can check a serum osmolality. If the serum osmolality is normal, then it cannot be a true hyponatremia. A true hyponatremia should always have a low serum osmolality. The step 2 is to identify symptomatic hyponatremia, because if a patient is symptomatic, the treatment is more important. The etiology and cause can be later found out. But if patient has acute hyponatremia, now acute hyponatremia, what it does is it reduces extracellular osmotic pressure. Now, because of reduced extracellular osmotic pressure, there is a fluid movement into the cell, which causes cellular swelling. Now, in places with confined spaces like skull, this can cause cerebral edema herniation. So patient may present with seizures, deep somnolence, GCS less than 8. Now, this is a problem in patients with liver disease, because the most of these patients can be in hepatic encephalopathy. So to attribute the altered mentation only to hyponatremia becomes very difficult in patients with hepatic encephalopathy. But if there is a witness drop, suppose the sodium was 130 and it has drastically reduced over 2 days to, or 1 day to say 105, then it is a witness drop and that needs to be treated urgently. Now, step 3 would be to exclude AVP independent etiology. So most of the cases of hyponatremia are associated with increased AVP, that is antidiuretic hormone. Now, except for when there is high consumption of water but low consumption of solutes. Now, this can happen in patients who present with beer protomania, like they just have a lot of beer where there is no solute intake but a lot of fluid intake, primary polydipsia, or diet with low solutes like tea and toast diet. So these patients can present with hyponatremia, and they are independent of AVP secretion. So this can be checked by checking urine osmolality. If urine osmolality is less than 100, then it is an AVP independent etiology, and hence these need to be ruled out. And once these all 3 are done, the step 4 would be volume assessment. Now, in patients with cirrhosis, physical examination alone lacks specificity and sensitivity. Even checking parameters like, say, fractional excretion of sodium or fractional excretion of urea has low sensitivity. Overall, they are categorized as either hypovolumic, euvolumic, and hypervolumic. Now, coming to the first 2, that is, suppose hypovolumic. So patients can have fluid depletion due to use of diuretics. There can be GI loss due to prolonged vomiting or prolonged diarrhea. So they can present with hyponatremia. So it can be either renal loss, that is example diuretics, or extra-renal loss, which can be differentiated by checking urinary sodium. Now, euvolumic category is something which is difficult to diagnose and manage. So patient's volume status looks normal, but still has hypoproteinemia. This can be seen in patients with hypothyroidism, pituitarism, adrenal insufficiency, renal failure, of patients are on some medicines which can lead to SIADH. Now, talking about regulation of serum osmolality in humans. So first is the increase in serum osmolality is sensed by the hypothalamic receptors. And in response to that, they release AVP. This AVP acts at two places. One is the collecting duct in the nephrons, where it binds to the V2 receptor, increases the expression of aquaporin 2, and increases water reabsorption, and hence reduces the serum osmolality. Other place it acts is the thick ascending loop of Henle, where it acts on the V2 receptor again, increases phosphorylation of sodium potassium 2 chloride channel, and again increases salt and water reabsorption. Now, this salt absorbed from the thick ascending loop increases interstitial osmolality and aids in water absorption from the collecting duct by aquaporin 2. Now, in patients with cirrhosis, there is a non-osmotic stimuli for AVP release. For example, hypotension, nausea, hypoglycemia, pain, post-operative state, or medications. So there is AVP release, and it acts to increase salt and water reabsorption because that's its job, and it has been released in response to non-osmotic stimuli. Also, there is RAS activation. So, because of increased renin-angiotensin aldosterone secretion, there is increased water and salt reabsorption associated with decreased GFR. Now, what happens is patients with liver disease have hyperammonemia. They have increased glutamine synthesis and in the brain cells, and there is therefore increased intracellular osmolality in the brain cell, that is astrocyte. Because of increased intracellular osmolality, water shifts from extracellular space into the astrocyte, causing astrocyte swelling. Now, as a mechanism to reduce this swelling, astrocyte excretes certain osmolytes like myoinositol, taurine, and that's a defense mechanism to reduce the astrocyte swelling. Now, in patients with hyponatremia, again there is decreased extracellular cellular osmolality, and hence water will again shift into the astrocytes. So already in patient with liver disease, astrocyte swelling is there because of hyperammonemia. To add to that, hyponatremic insult and cell swelling can lead to astrocyte dysfunction, and that can lead to breakdown of blood-brain barrier and cause damage to myelin production cell and lead to osmotic demyelination. Now, enough talk about hyponatremia, but is hyponatremia just a bystander, or it is a unique marker of disease progression? Or does correcting hyponatremia improve outcomes? And if so, what is the price of attempting such a correction? And if not, then who should be treated? Now, though hyponatremia is a mortality marker, it is associated with worse outcomes in patients with liver disease, but there has not been any improvement in mortality in patients in which hyponatremia has been corrected. Obviously, when you correct hyponatremia, there have been improvement in markers such as quality of life or say neuropsychiatric improvement, but that has not really led to improved outcomes. Even patients with hyponatremia with cirrhosis where V2 receptor antagonists like satavaptan, tolvaptan have been tried, but they have not really caused improved in outcomes, and the mortality in use in correcting versus non-correcting hyponatremia remains the same. The problem of attempting such a correction is this damage to blood-brain barrier and osmotic demyelination. Plus, patients with liver disease also have malnutrition, they have co-current hypokalemia, and overall are more susceptible to osmotic demyelination syndrome. Hence, such correction should be thought twice before attempting in patients with cirrhosis. Now, how can we correct hyponatremia? The first thing we need to do is stop diuretics, stop beta blockers, correct hypokalemia, hypomagnesemia, any acid-base abnormality that is there. After that, there are few things which you can do. One is water restriction. But in patient for water restriction to be effective as a treatment for hyponatremia, the restriction of water should be less than the amount of urine output. Now, in patients with cirrhosis, when already urine output is low, attempting water restriction lower than that becomes difficult. So it has limitations. Other thing is use of albumin, which has shown in multiple studies to increase the serum sodium levels and improve outcomes in patients with liver disease. Other things that can be tried is V2 receptor antagonist like satavaptan, tolvaptan, but there has not been any literature where it shows an improved outcomes. Now, the problem with using V2 receptor antagonist in this scenario is for V2 receptor antagonist, tolvaptan was used to treat ADPKD in TEMPO trial. Now, patients recruited in that trial developed liver dysfunction and raised bilirubin enzymes. So, FDA has issued a warning against using such drugs in patients with liver cirrhosis. Hence, the treatment it becomes difficult. Also, if there is an acute hyponatremia, then treatment should be done, but there has to be a level. So the recommended correction is 4 to 6 milliequivalents over 24 hours. So suppose if patient's sodium is 110 and you start correcting with say 3% saline if it is acute hyponatremia with symptoms, your target over next 24 hours should only be 114 to 116. It should not overshoot that, because as I said, they are prone to osmotic demyelination because a lot of other problems like hypokalemia, malnutrition, alcoholism in itself. And if we overshoot, they are more prone to develop this osmotic demyelination syndrome. If we overshoot, the sodium should always be brought down to the target level. Suppose if you're correcting hyponatremia sodium 110, you give 3% saline and you overshoot to 120, then you have to bring the sodium down and attempt to get it down to say 116 or 117 over next 24 hours. Because if you don't correct that and sodium keeps on increasing, then the chances of developing osmotic demyelination is going to be high. So who should be treated? One is the patients whose sodium is less than 120 or who have severe symptoms of hyponatremia. Or suppose if somebody who is planned to undergo liver transplant with sodium less than 125, the sodium needs to be treated. The rationale for that being, once you do a liver transplant, the sodium level goes up. So suppose if patient sodium was 115 to begin with and we do a transplant, the next day sodium goes up to 140, then there is a risk of osmotic demyelination syndrome. And these cases have been reported in literature where patients have developed osmotic demyelination syndrome post liver transplant. And hence such patients, the sodium should be corrected more than 125, somewhere around the range of 130 before they are taken in for a liver transplant. So now moving on to potassium. Now hypokalemia, the prevalence is 40%. And serum potassium is a very insensitive marker of total body potassium because most of the potassium is intracellular. Now, cirrhotics may be normokalemic, but their intracellular stores are always depleted. And the cause being there is secondary hyperaldosteronism. Now, coming back to that flowchart before, reduced intra-effective arterial volume causes renin-angiotensin aldosterone secretion. This secondary aldosterone secretion will cause increased potassium excretion and hence hypokalemia. But this is counteracted by patients because of reduced GFR. Reduced GFR causes reduced distal delivery of sodium and hence reduce potassium excretion. Now, these two mechanisms are mutually opposing and lead to potassium excretion to our normal levels. Now, if there is hypokalemia in patient with cirrhosis, it could be because of respiratory alkalosis. Now, respiratory alkalosis is the most common acid-base abnormality in patients with end-stage liver disease, and it can cause transcellular shifts. Vomiting can cause hypokalemia, which can be because of increased aldosterone due to volume depletion and also because of increased bicarb. Vomiting would cause alkalosis, increased bicarb, increased distal delivery, and potassium excretion. There can be hypomagnesemia. Now, patients with cirrhosis are prone to have hypomagnesemia because of poor diet and malnutrition. And attempting potassium correction without correcting magnesium, potassium will not get corrected because it acts as a gatekeeper of the channel. Malnourishment, diarrhea, and diuretics are other few causes of hypokalemia. Hypokalemia can precipitate hepatic encephalopathy. This is the most important point because it leads to intracellular acidosis in proximal convoluted tubule cell, and that causes increased ammoniogenesis. Now, acid-base abnormalities, respiratory alkalosis, that's the most common. It is most probably due to reduced liver clearance of progesterone, which has a direct effect on CNS respiratory centers, and it is also potentiated by increased estrogen levels. It is benign, and complications like hypocalcemia, hypotension almost never occur in respiratory alkalosis in cirrhotics. Metabolic alkalosis is common due to diuretics and volume depletion in patients with cirrhosis. Now, high anionic cap metabolic acidosis, lactic acid. Now, lactic acid is generally produced due to anaerobic glycolysis, and in skeletal muscle, that's the most common site. And generally, after production, with production of lactic acids, there is increased production of H+ ions, that is acid. And then lactic acid is again converted to pyruvate, where those H+ ions are consumed. This happens in liver and kidneys. Now, when liver dysfunction is there, this clearance of lactic acid does not happen. And hence, increase in lactic acid correlates with disease severity. Generally, it is type B, which is unrelated to hypoxia. unless there is some super added complications like bleeding, sepsis, shock, spontaneous bacterial peritonitis, tissue hypoperfusion, and hypoxia. That will cause super added type A lactic acidosis on that and will lead to severe metabolic acidosis with high anionic gap. Medications like entecavir, metformin, and salicylates are known to cause high anionic gap metabolic acidosis. Also, high anionic metabolic acidosis can also be seen in patients with concurrent other diseases, like suppose patient with end-stage liver disease has end-stage renal disease or renal failure, or there is alcohol on a starvation ketoacidosis that can cause high anionic gap metabolic acidosis. Now, non-anionic gap metabolic acidosis, which is the hyperchloremic acidosis. Anionic gap is calculated by sodium minus chloride plus bicarb. So normal anionic gap metabolic acidosis can happen when there is reduction in bicarb is associated with increase in chloride. So the product of chloride and bicarb remains the same. So the anionic gap remains the same. This can happen in patients with cirrhosis due to lactulose-induced diarrhea and GI bicarbonate loss. It is common in patients with liver disease due to other causes like Wilson's disease, glycogen storage disease, PBC, and that will cause distal renal tubular acidosis. Now coming to hepatorenal syndrome. Hepatorenal syndrome is a serious complication and it is associated with high morbidity mortality. It is characterized by circulatory functional changes in kidneys that overpower the physiologic compensatory mechanism. The problem with checking creatinine in patients with liver disease is it always underestimates the liver function. So suppose if creatinine comes as 1.1, we feel, oh, creatinine is normal, wonderful. But actually that's not the case because patients with liver disease, creatinine underestimates the liver function. That is because of impaired hepatic production of creatinine, reduced muscle mass, malnourishment, tubular secretion, and bilirubin can interfere with calorific methods of estimation of creatinine. To overcome this, there are several things like we can calculate 24-hour urinary clearance, or we can measure cystatin C. But those methods are expensive and cumbersome. So we stick to the creatinine value, which is almost standardized and commonly used by everybody and available everywhere and relatively cheap. Now, acute kidney injury is a common complication, and HRS is one of the causes of AKI. It is a functional form and potentially reversible. Helving et al. In 1932 was the first to describe acute kidney injury. It was described in patients who had undergone biliary tract surgery. And there were cascades of events associated with intense dilatation of splanchnic arterial vasculature in settings of cirrhosis. And it caused progressive renal failure. But to a surprise, when they were biopsied, the kidneys were absolutely normal. So it is a functional damage. And when such patients underwent correction of portal hypertension, either by transplantation or medical therapy, the kidney functions became normal. And also when patients whose kidneys were harvested and transplanted into a non-cirrhotic patient, they function absolutely normally. Hence, it was concluded to be a functional damage rather than a structural damage. Now, acute kidney dysfunction occurs in 15 to 25% of hospitalized patients with cirrhosis. 10 to 30% is HRS. The annual frequency that once in a year patient will develop this is 8 to 40%. And according to Fede et al., 20% of cirrhotic patients with diuretic resistant ascites potentially develop HRS. Incidence would be 18% at 1 year and 39% at 5 years, according to study by Genies et al. So it is quite common and needs to be kept in mind in any patient with renal dysfunction in background of cirrhosis. Now, prevalence of HRS increases as liver disease worsens. And it was reported to be 50% in patients who are on waiting list for liver transplant. Now, interestingly, the incidence has dropped in recent years because of better understanding, better awareness, better treatment options. But long-term survival still remains poor, as the only effective treatment is liver transplant. Median survival, if left untreated for type 1, is 2 weeks, and type 2 is 4 to 6 weeks. Now, HRS is classified into two types, type 1 and type 2. Type 1 would be rapidly progressive form where median survival is only 2 weeks. It is defined by creatinine level doubles to a value greater than 2.5 in less than 2 weeks duration. And it can be precipitated by infections like bacterial peritonitis, GI bleeding, acute liver injury, acute and chronic liver disease, or surgical procedures. Now, type 2 is the slowly progressive type. Median survival is 6 months, and it generally presents as diuretic resistant ascites, but it can also lead to type 1 HRS. It can progress to type 1 HRS. Now, this kind of classification is an old form of classification. As our knowledge of acute kidney injury has improved, so is our knowledge applicable to HRS. Like initially, acute kidney injury was defined as creatinine more than 2 or 1, and there was no standard definition. But after Rifle criterias and Akin criterias and KDIGO criterias, there is a uniform definition for AKI as creatinine more than increase in creatinine more than 0.3 milligram in 48 hours, or urine output less than 0.5 ml per kg per hour for 6 hours. That's the standard definition for acute kidney injury. Now, International Club of Ascites has also incorporated this definition into diagnosis of HRS, but they have omitted urine output. They have omitted urine output for the simple reason that patients with ascites are already have a low urine output due to avid salt and water absorption due to activation of renin, angiotensin, and aldosterone. But if we still use that criteria, there can be early identification of patients with AKI, and hence treatment can be initiated early. So according to International Club of Ascites, AKI can be classified as stage 1, where increase in creatinine more than 0.3 or more than 1.5 times the baseline. At 1A, the creatinine is less than 1.5, and 1B is creatinine more than 1.5. The significance of classifying it as 1A and 1B I shall discuss in coming few slides. Now, increase in creatinine more than 2 times. So suppose 0.8 was the baseline creatinine, and now it is say 1.8. So that's like increase in more than 2 times. That would be a stage 2 AKI. And stage 3 is when it is more than 3 times or more creatinine more than 4, or patient is started on renal replacement therapy. If we don't know the baseline, the last creatinine anytime checked in last 3 months is used as a baseline creatinine. Now, this, as I said, HRS type 1, type 2 is an old classification. So the criteria was there is no response to diuretic withdrawal or 2-day fluid challenge with albumin, say 1 gram per kg per day. Patient has cirrhosis with ascites. There is no shock. There is no use of nephrotoxic drugs, no structural kidney injury, that is no proteinuria, hematuria, and ultrasound shows normal kidneys. So this is mandatory for diagnosis of HRS since it's a functional damage. So there should be no evidence of any structural kidney injury. Now, this classification has evolved into, so the new name for HRS type 1 is HRS AKI, where the increase in serum creatinine of more than 0.3 milligram per DL within 48 hours or more than 1.5 times from baseline. And rest of the criteria remain the same. Whereas HRS type 2 has been renamed as HRS non-AKI, NAKI. And they are further estimated into acute kidney disease and chronic kidney disease. So if estimated GFR is less than 60 for less than 3 months, then it is acute kidney disease. And if it is more than 3 months, then it is known as chronic kidney disease, HRS CKD. And the pathophysiology remains the same as we discussed. But there can be additional causes of increase in creatinine in patients with liver disease, like adrenal insufficiency is common in patients with cirrhotics. Tense ascites can cause intra-abdominal hypertension, and more than 12 millimeters is known to cause acute kidney injury. And such patients, when ascites is drained under the cover of albumin, they seem to respond to it by reducing their creatinine values. Another underestimated cause of AKI in patients with cirrhosis is cholemic nephropathy or bile cast nephropathy, where bilirubin more than 10 gets deposited into renal tubules, causes obstruction and kidney injury. So approach would be to first of all remove all the risk factors, that is nephrotoxic drugs, vasodilators, NSAIDs, diuretics. If there is infection or spontaneous bacterial peritonitis, they should be treated. So suppose increase in less than 2-fold. So my creatinine was 0.8, now it is 1.1. So it is still an AKI, it is still 1A, but where we do only risk factor management. This is the reason why they have classified it into 1A and 1B. So if patient's creatinine is less than 1.5, we can wait and just monitor. But if it is more than 1.5, then action needs to be taken, like higher volume expansion has to be tried with albumin. that holds true even if your creatinine is more than twofold, that is AKI stage 2 or stage 3. If there is resolution with volume expansion, you just monitor. But if there is no resolution, then there are some things which can be done. One is urinary biomarkers, which we will speak about in a while. But if they are not available, we try vasoconstrictive therapy plus albumin, that is either noradrenaline plus albumin, terlipressin plus albumin. If that is available and if urinary biomarkers show ATN, then there is no use of giving vasoconstrictor therapy plus albumin. And in such cases, renal replacement therapy has to be offered. But if it is consistent with diagnosis of hepatorenal syndrome, then in such patients, first vasoconstrictor and albumin therapy has to be tried. And if there is no response to that and patient's condition is worsening, then obviously we have to move on to renal replacement therapy. Now, to differentiate AKI with ATN, is very difficult in patients with renal disease. So there are certain markers which are used, like urinary sodium or fractional excretion of sodium and low urine osmolality. But they can be abnormal. Like suppose urinary sodium may be elevated in patients on diuretics. ATN may also be associated with low urinary sodium. Hence, they are no longer recommended. Even fractional excretion of urea, it shows slightly better sensitivity specificity, but still it is not currently in use. The best way possible ahead is urinary biomarkers, that is kidney injury molecule 1, N-gelatinase associated lipocalin, that is NGAL, liver type fatty acid binding protein, that is LFAB. Out of which NGAL is the one which is most widely used in patients with cirrhosis, and cutoff is more than 220 microgram per gram of creatinine for 18. And it is an independent predictor of short-term mortality. So what these biomarkers do is they help us distinguish structural kidney problems from functional causes of AKI, and hence accurate and rapid diagnosis. Now, Belcher et al. Performed a multi-centric prospective cohort study, and they used markers. They used NGAL, interleukin 18, KIM1, and LFAB. And they were elevated in patients with in liver disease with kidney injury due to ATN, but they were normal in patients with hepatorenal syndrome. A similar study was also conducted by Verna et al. And they also concluded that trace urinary levels of NGAL may serve to distinguish functional damage from ATN. It was later also confirmed that it predicts outcome. So NGAL levels were significantly higher in persistent AKI with transient AKI. Also, it were higher in type 1 HRS from other cause of HRS. Now, treatment is very important due to high mortality rate. So intravascular volume depletion has to be avoided. You should stop the diuretics. If there is severe diarrhea because of lactulose, that has to be withheld. GI bleeding has to be tackled. Large volume paracentesis should not be done without colloid administration. Nephrotonic toxic drugs has to be avoided. And if there is SBP or any other bacteremia, it needs to be treated. Now, medical therapy of HRS is reversing the underlying vasodilatation with vasoconstrictors, with increasing the circulatory volume by giving colloid. It is a temporary measure until we have a definitive treatment like liver transplant. Some patients are also eligible for TIPS, and liver transplant is the ultimate treatment of choice. Now, a goal-directed therapy in improving kidney function is by vasoconstrictors. Though we have multiple options. One is terlipressin plus albumin, midodrine octreotide plus albumin, and norepinephrine plus albumin. They all have been used, and there are various studies which have compared the three and found out that more or less they all are similar in their action and outcomes. Terlipressin is a selective V1 receptor agonist, and it is safe. Only thing is when it can lead to severe digital ischemia, it can lead to splanchnic ischemia, can lead to fluid overload, arrhythmias, and cardiovascular disease. It happens when the dose used is quite high. So generally the dose given is 1 milligram over 4 to 6 hours bolus in combination with albumin. It can also be used as continuous infusion. The continuous studies which have compared boluses and continuous infusions have showed that continuous infusions, the overall dose is less and the chances of complication would be less compared to the bolus dose. If serum creatinine does not reduce more than 25% after 3 days, then the dose is increased. If there is no response, the treatment should be discontinued and renal replacement therapy needs to be planned. The another alternative to terlipressin would be norepinephrine, which is also used in combination with albumin. And there are various studies which compare it with terlipressin, which I'll come to in a crowded chart over next few slides. Now, midodrine is a alpha-1 adrenergic agonist. It is metabolized by liver into desglycomidodrine and is excreted in urine, and it is a good alternative in combination with octreotide to terlipressin. So these are the various studies which have compared terlipressin versus placebo, terlipressin versus norepinephrine, terlipressin versus midodrine plus octreotide. The gist is that terlipressin is the single best treatment, but when comparison with norepinephrine and midodrine, they are non-inferior. So they can be used as a cheaper alternative to terlipressin in patients with cirrhosis. TIPS is generally effective for treatment of diuretic resistant ascites, and there are multiple studies which have evaluated TIPS in non-transplant candidate with HRS. So it does not affect overall survival, but the limitation is it can worsen hepatic function and precipitate hepatic encephalopathy if the patient is not chose correctly. Hemodialysis is frequently used to control azotemia and maintain electrolyte imbalance in patients with severe AKI. The problem is hypotension during dialysis because of reduced effective circulatory volume, out of which if 200 ml is going to come in the dialysis machine, it can cause a lot of hemodynamic instability, especially if such patient is on terlipressin or something, or some arrhythmogenic electrolyte abnormality like hypokalemia. It can cause a lot of problems. So risk must be carefully weighed against benefits. It can serve as a bridge for transplant, but it does not improve long-term survival in patients who are ineligible for transplantation. Various modalities have been tried, like CVV HD or hemodialysis. Generally, CVV HD, that is CRRT, is reserved for patients who are mechanically ventilated and who are on multiple inotropes with a lot of hemodynamic instability, while patients who are not mechanically ventilated were tried on hemodialysis. And 30-day survival time in study by Witzke et al. Was nil in patients who received CRRT, and it was about 50% in patients who require HD. So to say that patients who go to a stage requiring renal replacement therapy, the outcomes are very bad unless we can offer them a liver transplant. Some other innovative technologies, extracorporeal therapies like MARS, molecular adsorbent technique, has been tried, where albumin impermeable membrane separating patient's blood from albumin dialysis. So this is the patient blood, it runs over here, and this is the albumin which runs over here. Albumin is regenerated by anion exchange resin and charcoal resin, and the dialysate circuit runs here. So the point of using albumin is that it will take up bilirubin and other toxins which are commonly seen. Having said that, this is very, very expensive, and it has not led to improved outcomes in patients with liver failure. Similar treatment with Prometheus and Helios has also been tried, where there are adsorbents which are used to remove bilirubin, but nothing frankly has worked except liver transplant in patients with liver disease. So these all serve as a bridge to let the patient reach the stage where he can undergo a transplant, but without transplant independently, these have not led to really good outcomes. A liver transplant remains the treatment of choice, and recovery of renal function after renal transplant is not universal. So it is seen in 60% of patients, but in remaining 15% there is partial recovery. 1/4 still there may not be recovery. So, and point is HRS has a impact on survival. So 3-year survival rate without HRS is 80%, but with HRS is 60%. And if patient is on hemodialysis, the mortality risk is around 2 times higher than patient who is not on hemodialysis. So these are certain guidelines from European Association, a very crowded site. I'm very sorry for that. So I'm just going to go over the strong recommendations. That is, vasoconstrictor and albumin are recommended in patients who have HRS more than stage 1A, and they should be treated with vasoconstrictors and albumin. Terlipressin plus albumin should be the first line therapy. Terlipressin can either be used as bolus or it can be given as continuous IV infusion. This causes reduction in global daily dose and thus adverse effects reduce. In case of no response, it should be increased. The dose should be increased. Albumin should be used at a dose of 20 to 40 grams per day. That is 2 bottles, 200 ml per day. Noradrenaline can be used as an alternative to terlipressin, but it requires a central line and transfer to ICU. Midodrine plus octreotide can be an option when these two are not available. Treatment should be stopped only when there is complete resolution of HRS. Partial resolution can also be seen, and adverse effects should be we should be on a lookout for adverse effect like ischemic events. Suppose patient has blue fructose, blue fingers, or arrhythmias, or chest pain, or severe diarrhea. These all can be attributed to terlipressin, and hence those should be reduced in such patients who develop such complications. Now, terlipressin plus albumin has also been tried in HRS-NACI and is an effective treatment. But what happens is they temporarily recover, and as soon as you stop it, there is always the recurrence. And for such patients, the liver transplant is the only therapeutic option. The best therapeutic option for AKI HRS is liver transplantation. Now, coming to what if renal functions don't recover? Suppose if renal functions recover with all this patient is in, say, normal renal function or CKD stage 1, 2, or 3A, then we do a liver transplant alone. After liver transplant, if there is non-recovery of renal function or renal functions deteriorate to a stage requiring dialysis, in such patients, a kidney transplant can be done later after the liver transplant. Suppose if a patient has AKI whose GFR, now various countries have different guidelines. So suppose US, the GFR criteria is 25, but Europe and Canada, the GFR criteria is 30. Or they need dialysis. So we look at the dialysis time. If patient has a persistent AKI which lasts more than 6 to 12 weeks, depending on the country you stay in, then they should go for simultaneous. But if it is of less duration, suppose patient came today, he's started on dialysis, and we transplant him within 2 weeks time, we do liver transplant alone and look for recovery of renal function. But if patient has CKD, say anything more than stage 3B, or if we do a kidney biopsy, we found that 40% of glomeruli are sclerosed, there is 30% interstitial fibrosis, and all such patients are offered simultaneous liver kidney transplant, because post liver transplant, they are prone, the kidney disease is known to progress, and eventually they would develop a kidney disease requiring transplant. And sequential transplant don't have as much good outcomes as a simultaneous liver kidney transplantation. With this, I'll conclude my talk, and I'll be happy to take any questions if there are any.
Thank you, sir. At present, there are no questions. Sir, you have discussed with your thorough knowledge of as a nephrologist about various kidney disease states and their management with patient with liver cell failure. Sir, you have made your presentation very live and interesting with your excellent slides, and especially of pathophysiology and other slides. Various modalities and guidelines of management. Sir, it was very well discussed. Thank you very much, sir. Sir, now I will request our President, Dr. B.L. Deshmukh, to felicitate you. Thank you, sir.
Sir, this is bouquet for you.
Thank you so much.
Sir, IMA Upparna for you.
Diary. And sir, this is the diary, our financial year diary. You can keep on the table. Thank you, sir.
Thank you. My pleasure. Thank you.
We'll be sending you the diary.
Thank you, sir. Now, since morning, we have been discussing the spectrum of liver diseases and its management. And ultimately, it leads to liver transplant. Now, we have the man who actually does liver transplant, Dr. Dinesh Zhirpe, sir. He will be speaking to us on challenges in liver transplant surgeries. Dr. Dinesh Zhirpe, sir, is a consultant in Department of Liver Transplant and GI Surgery at Sahyadri Group of Hospitals in Pune. He has accumulated an experience of more than 1,000 laparoscopic surgeries and more than 300 liver transplants. He has been awarded with Young Scholar Award in GI Surgery. Dr. Dinesh Zhirpe has done MS general surgery from Topiola National Medical College, Mumbai. He was an assistant professor at BJ Medical College, Pune. He has underwent specialty training in gastrointestinal surgery and liver transplantation at Apollo Hospital, Chennai, and completed his super specialty degree in the same field with ample experience of robotic, advanced laparoscopic, GI surgeries, and multivisceral transplantations. He secured highest marks to become All India topper in his final examination and was awarded gold medal for the same by Vice President of India. He has also completed International Scholars Fellowship Program at Asan Medical Center, South Korea, in the field of liver transplantation and hepatobiliary surgeries. He has been actively involved in living donor liver transplantation, deceased donor liver transplantation, and various hepatic resections. He is a reviewer for indexed journals, including case reports of American Journal of Gastroenterology. He is a member of many national and international associations. I welcome Dr. Dinesh Jirpe, sir. Over to you, sir.
Am I audible, sir?
No, no, sir.
Is it okay now?
Yeah, yeah. Hello.
Hello.
Now it is okay, sir. Yeah.
Okay, okay, sir. And are my slides visible to you?
Yeah, the slide is visible, but the volume of your speech is little low.
Okay, I'll just change my earphone.
Yeah, yeah. अनिकेत आवाज थोड़ा सा कमी है किसी हेलो हेलो यस सर हेलो अनिकेत सरांचा आवाज काय येत नाहीये बघ हेलो
Hello.
Yes, sir. We can hear you now. Hello.
Hello. Can you hear me, sir?
Yes, sir. We can hear you loud and clear.
Okay, okay. Then
Go ahead. Yeah.
okay, sir. Good. So basically, today's topic is challenges in liver transplant. So you must have heard a wonderful topic sessions from Madam Sir regarding adult and pediatric diseases and the spectrums of liver diseases. So now, once we decide that we have to go ahead with the transplant, what are the different challenges? These there are a few important points we are going to discuss in this. So just whenever I was preparing this slide, my dad was near. So I just asked him, how do you feel about this slide? So he said, अच्छा म्हणजे ट्रान्सप्लांट नाही केलं तर स्मशानभूमी असं काय दाखवतोय का? I told no. Then I realized that he is not wearing his specs. So I told him, no, it's a hot burning issue. So I thought it's better to put this slide. It's like a chai pe charcha. So then he said, okay. So let's go ahead with the 1 second. The presentation. So obstacle is the path for some problems. So or some progress. So when it was started in 1964, definitely it was like that. So nowadays, at least we have a path, but still the obstacles are not less. There are multiple issues. So we will be discussing the challenges in three important parts. One is pre-transplant problems or challenges. Then during transplant, what we face, and then what are the different issues regarding post-transplant management. So most important things is counseling. So during pre-transplant, there are few issues. One is counseling. When the patient comes to us, you might feel this topic is like a PSM lecture because it won't involve multiple different studies, but it will be like a practical issue discussing scenario. So when people come to us, we explain them that, yeah, you have liver issues. These are the decompensations you have, and ideally better to go ahead with the transplant. It is very difficult for them to accept that, okay, I have a liver issue so much as that it will require a liver transplant. So they fail to accept that initially, and they tend to change the doctor rather than changing the liver. So I mean, the compliance is very less regarding that. So we try to explain them as if we are their relatives, but still there are multiple issues which come into the in the scene. So once there is a denial that, okay, I don't have that much problem that I need a transplant. Second, there is the problem in understanding the severity. So MELD score is a wonderful score which is developed by Professor Kamath, model of end-stage liver disease, which can be calculated by any phone, Android phone or iOS phone. They have a proper apps for medical calculations. So if you calculate a MELD score, you will easily get the mortality, morbidity without a transplant. So if the patient's MELD score is more than 30, the mortality is around 50% at the end of 3 months, which is quite high. Means out of two, one may not survive at the end of 3 months. But the patients, they fail to understand that that much is the severe problem. If you discuss cancer, normally for stage 4 also, we tend to tell them that, okay, at the most 6 months, 7 months. But here we are talking about 3 month mortality, and which is quite high. So and it is easily available. So even relatives can also calculate the MELD score. But how much severe is the problem? They fail to understand that thing. Second, trial and error. So then they try to do other options, other remedies, other doctors. So unless and until they find that, okay, somebody is telling them that, okay, no, we will try without transplant, they will stick to that person. And then once they feel that, no, we are not getting good outcome, they will change the doctor. But that should not be there. So that is an important challenge which we face. So anyways, once after doing all this thing, when they realize that, okay, now I think transplant is an answer for this, but they will not, they will take opinion poll. So they will ask everybody around them that, what do you feel, what I feel personally is they should ask to a proper specialist, hepatologist, transplant surgeon, or those who have undergone the transplant. So that opinion poll is vitally important rather than a general public opinion poll. Then Mahacharcha. This is a very important part of any family who is undergoing a procedure of liver transplant. So we normally say that it is not a decision of a single person. It is a decision of family. And obviously Mahacharcha has to be there, but it should be a fruitful thing. So there should be some positive points, negative point. Obviously a transplant has its own side effects, its own risk, but it comes with its advantages also. So that has to be discussed properly. And then once sometimes one of them might give the other options that, oh, you can try other pathies, you can do. So we are with the due respect of all pathies and all other remedies, most important thing, we should understand our limitations. If we go beyond limitation, then the severity at which patient presents to us is quite delayed. So normal, according to the general scenario all over world accepted, is if the MELD score is more than 15 or at least more than 17, the patient should be considered for liver transplant. But in such cases, what we see is that patients who are referred to us, their MELD score is around 30, 34, 36. So which is quite a delayed stage. Other important problem which we face is challenge is that telling the primary physician that what a beautiful treatment liver transplant is, because many of the doctors, they also have many myths about the liver transplant, that the outcome may not be so good, there is the cost involved is too high. So rather than going for that, rather not go to that road only. So that should be avoided. So obviously it is our duty to tell them, educate them, because it is a high-end surgery, a tertiary care level center experience. So everybody may not have the equal exposure for the liver transplant and their outcomes. But awareness is vitally important for that. So once we complete the counseling and patient and the family is ready for the liver transplant, the biggest thing or the challenge which we get is the cost. So the cost is definitely, compared to other surgeries, is high, but there is a reason for it. So we as a team, as a hospital, we always try to make it that as much as affordable for the patients. But there are some things which we need to raise. So funding is definitely is an issue. So when there is the patient and the family is not able to raise the fund, we tell them the option of Chief Minister Fund, Prime Minister Fund, the funds which is provided by the Transplant Foundation, and crowdfunding is another other options which commonly used nowadays, and it gives you a proper support. So we had one patient who was a rickshaw driver, and he had 12 to 13 friends. The all transplant fund was gathered by his all friends, and that too with the crowdfunding. So that much is the power the whole family or the supportive team has. So fundraising definitely is an issue, but we tell them, we give them all the options, and we also give them support from our side, from the technical team, from the hospital team, from the surgical team. Everybody helps them for that. Then optimization. So once they are ready for the transplant, consent for the transplant is done, the family is ready, funding is ready. The other major issue is the optimization. So as I told you, the patients are present to us quite delayed phase. They have other most important one is the comorbidity. Patient may have a coronary artery disease, they may have diabetes. Along with that, there are certain syndromes associated with the liver cirrhosis, which is hepatorenal syndrome, which Dr. Mann has explained in detail, hepatopulmonary syndrome, and portopulmonary syndrome. I'm not going to go into the details of it, but managing these things also takes time. It also costs money, and that leads to increase entire total expenses. So, and the outcome also is definitely different as compared to those people who don't have these syndromes. Second most common for which the patient comes to the casualty or to the physician is ascites, which may have a SBP like spontaneous bacterial peritonitis, or the ascites causing so much distension that patient is breathless, patient is not able to eat properly because of the tense ascites, and GI bleed. So these are interrelated things. Like if you have a GI bleed, the chances of bacterial translocation is high. Patient lands up in spontaneous bacterial peritonitis, and then patient lands up in ICU sepsis. So managing these things are quite critical and should be managed at a proper center. Hepatic encephalopathy is a common problem. Along with that, drug abuse. So we commonly see patients who have alcoholic also, and they land up in liver cirrhosis. So managing them is also a different issue, because there has to be an abstinence by government also. It is given that for a cadaveric donor at least 6 month abstinence should be there. So sometimes people they may not get that much time after the abstinence also, but that issue, that challenge is also there with us, that if the option of living donor we have to keep in front of them, that if there is somebody from the family donate, then maybe there is a chance for a liver transplant. But still there are certain stringent criteria for it. So if we follow that, then only we are able to go ahead with the transplant. So how do we know that how the patient is behaving, how what will be the prognosis? So we have a proper assessment protocol. Once the patient comes to us, is willing for the transplant, we evaluate recipient completely with initial biochemical investigation, then radiological and imaging investigation, and then followed by some functional investigations. So this is our entire one of the protocol for the cryptogenic etiological DCLDs. I'm not going to going into the details of the protocol, but an overview we will give you that we do a metabolic workup like copper studies, iron studies. Then we do an autoimmune workup, which is asthma, ANCA antibody, ANA, anti-neutrophilic antibodies. Then virological workup we have to do to prognosticate post-transplant scenario like CMV, IgG levels, varicella zoster, IgM, IgG positivity. Then endocrine workup we normally do. Mainly in that we do a thyroid function test. So for a female patient, we do mammography more than 35 years of age, and pap smear is also done, and the gynecological clearance has to be taken. And then tumor markers, obviously. So for all the patients, tumor markers are also compulsory. Normally we do CEA, CA99 and alpha fetoprotein for the liver, CA125 for the females, and prostatic specific antigen PSA for the male. So once we do these evaluation, then we have a specific system-wise evaluation. So cardiac evaluation is there. So in cardiac evaluation, these are the normal things like ECG, 2D echo we have to do. But dobutamine stress echo is also done. Along with that, a stress bubble echo we do to see if there is any shunting through the left to right shunts, and what is the importance of it. We diagnose hepatopulmonary syndrome also along with that. Then cardiac angiography, commonly we do if the patient is a non-diabetic for more than 10 years, or if there are any ECG changes in the in ECG, if there are some changes, or 2D echo or double stress echo is positive for something. And if the pressures are too high on the evaluation, then sometimes we might need to do a right heart study. Pulmonary evaluation, we do routinely ABG, standing and supine position. So that helps us to diagnose orthodoxia. Then for pulmonary function test, which is not so commonly done nowadays because of the COVID, and other tests which are preferred. So HRCT is compulsory by the government also for any transplant for donor and the recipient. So HRCT is nowadays done routinely, but we also used to do it in as a protocol. So vaccination, once they are ready for the transplant, willing for the transplant, we vaccinate them to decrease the post-transplant infections and sepsis. So this is our protocol in which we vaccinate them. Now, the challenges regarding donor management, donor issues. So as we know, the transplant is of two types. One is living donor liver transplant and cadaveric liver transplant. So living cadaveric liver transplant is somebody like the one person who is brain dead, and the family of that person is willing to donate the organs. So that patient can donate liver, kidney, and other organs. So that is called cadaveric donor. So most important problems in cadaveric donor is that the donor can be present in any of the institute in Maharashtra or any place in the hospital. So managing that donor is quite a task. The blood pressure maintenance has to be proper. The sodium level should be maintained. And for peripheral hospitals, it may not be that much common to manage the donors. So that's why the outcome of that maintenance may not be good. So that is an important challenge which we face during a cadaveric liver transplant. Then retrieval timings, like if you have heart retrieval, kidney retrieval, liver retrieval, then the timing has to be adjusted properly, that every recipient should get the organ in a proper time. So like sometimes we had a donor in Pune last time, and they had a recipient for heart in Chennai. So their flight was in the morning 7:30 or 8 a.m. We reached near at the cadaveric hospital at 12 a.m. in the morning. So we have to wait for 6 to 7 hours. Then we have to ask to wait our recipient also to 6 to 7 hours. So all the induction, all the surgical procedures are to be managed according to the common consensus. So then transport of the organs. So last time when we had an organ from Kolhapur, and it was allotted to the Nashik Sahyadri. So transporting organ from Kolhapur to Nashik within few hours, it is quite a task. Obviously, we get a green corridor help, and all government authorities help us for that. But that is definitely a good, important challenge. The issue which is there is we do not have air connectivity that common as in other states. Like in Tamil Nadu, the major cities are quite connected by the air travel. Trichy, Madurai, Chennai, Visakhapatnam, and others. So nearby areas, it is very easy to travel. But from Kolhapur to Nashik, it becomes difficult. Luckily, we could get a air company which helped us to travel from Kolhapur to Mumbai and Mumbai to Nashik, and the organ was transferred within 4 hours. So which was a very good task, good work accomplished, but it is definitely a challenge. Then committee. So then the question of living donor liver transplant. So living donor liver transplant means, as we know that cadaveric liver transplant, you have to enroll the patient for a cadaveric list. But the problem is that there is a waiting. You may not get donor for 2 months, 3 months, maybe 1 year also. There is luck factor available for that. So the solution for that is a living donor liver transplant. That means if somebody in the family is willing to donate and is of the compatible blood group, that patient can donate 60 to 70% of that liver, of his liver or her liver, to the recipient. So that is called living donor liver transplant. For that, most important is counseling. The donor should know that what are the effects, side effects, how we are going to do. And then once both are ready, both are worked up properly, there is a committee. So government has to approve that these donors and this recipient, they are approved by us. That is a committee for that special. which approves that committee, and then transplant can be done. So other than that, once we are ready for the transplant, as we know that living donor in liver transplant, donor is the highest priority for us. We do not want any complication with the donor, because donor is not having any issue, but still he's donating his own organ to his relatives with a good will. So we take utmost precaution for every case, but for donor we have to be more cautious, and for that we do test every before surgery also. So every time before surgery we repeat all the tests, but sometimes there can be mild variation. Maybe the counts may be total counts may be little bit higher, or maybe HGOT, HGPT levels from 25 it might elevate up to 50, 45, which can be because of any trivial viral infection also. But in that case also we postpone the liver transplant and we wait till the donor lab becomes the normal. So all the lab has to be normal, then only we go ahead with the living donor liver transplant. So few points regarding cadaveric liver transplant, how it is done. So once the patients are ready that, okay, we want to undergo liver transplant, there is no donor in the family available, so we want to register. So the patient is registered to a zonal transplant committee. So basically in Maharashtra, there are 4 zones: Pune, Mumbai, Nagpur, Aurangabad. So in Pune zone, we have to give application that so and so patient with so and so blood group wants to register at our center. So after that registration, the patient's name comes in the waiting list according to the blood group. So if the patient is O positive, negative does not matter for a liver transplant. So if the patient is O positive, the list should be in the O waiting list. So once there is a brain death or declaration, or once there is a donor in any of the hospitals, the hospital has to notify to the zonal transplant committee that we have a donor and his blood group is O, B, whichever according to the patient's own blood group. So if the blood group is O, then the person who is top on the list in the O blood group allotted to the center is called. And then if he is not willing or is not well, then second and third person is called. So accordingly, the allocation is done. So once the allocation is that the liver is allotted to so and so hospital and so and so patient, then the retrieval of organ happens. So our team goes there and they retrieve the liver and they bring back it to the primary hospital where the organ is allotted. So where the organ is allotted, then till that time we do explant surgery. That means the old liver which is not good, we take out that liver, and the one which is retrieved from the donor, we implant that into the recipient. So this is a general scenario. So one important point which we need to know is the declaration of brain death. So there are multiple myths regarding that, but one important point which we need to know, that there is nobody in the world who is declared twice brain dead and has awakened from the death. So it is 100% sure that if the person is certified brain dead, for that certification you require 2 different properly designated medical persons certify it 6 hours apart, which are not the part of the liver transplant team, so or any transplant team. So if the 2 specialists, they certify that the patient is brain dead. So how do they certify? They obviously check all the cerebral reflexes and other parameters, but important test in that is an apnea test. So if apnea test is positive, it is again repeated after 6 hours, and if both apnea tests are positive, then only patient is considered brain dead. So before that, as why there are challenges in that. So that we need to know that there are some prerequisites to do an apnea test. What are those prerequisites? One is the patient's body temperature should be more than 35 degrees Celsius. The blood pressure should be more than 90 millimeters of mercury. So this is an important problem, because maintaining blood pressure requires quite an effort by intensivist, ICU specialists. So using the inotropes, vasopressors, the systolic blood pressure has to be maintained more than 90. The partial CO2 pressure should be between 35 to 45 millimeters of mercury. The electrolyte should be normal. Sometimes sodium level jumps up. So if the sodium level is more than 160, 158, still it should be within the normal limit, at least below near about 150. Then the apnea test is considered valid. So then pre-oxygenation. Patient is pre-oxygenated for more than 10 minutes, at least 10 minutes, with FiO2 of 100% and PO2 of more than 200 millimeters of mercury. Then ventilator is disconnected. And then the patient is observed for the respiratory movements. So positive test should be considered when there is increase in partial CO2 pressure from more than 20 millimeters of mercury. So if it was 45 before, it should be more than 65, or if there is more than 60 millimeters of mercury directly partial CO2 pressures. So in these conditions, the apnea test is considered positive. So doing apnea, finding proper specialist to certify apnea, it is definitely a task, and maintaining donor is definitely a task and a challenge. So why living donor liver transplant is considered in first hand? Because it has multiple advantages. First, as we know that in cadaver liver transplant, there is waiting list. So you can just register and pray for the donor or donor liver, but there is no guarantee or surety that you can get it. However, in living donor liver transplant, if somebody in the family is willing to donate, within few days, maybe 3-4 days also, you can, once you do the proper workup, the family relative can donate his the part of the liver to the recipient. So the transplant can be done within 3-4 days, or in case of ALF, it can be done within 1 to 2 days also. So there are multiple norms for that, but they have to be followed. So what is the biggest advantage for it? That is, there is no waiting period. So you can get it done as early as possible. Then we know that there is going to be a transplant after 4 to 5 days. So you can do optimization. But in cadaver, that doesn't happen. Anytime you may get a call in the night, the 2 a.m. that there is a donor here, so and so. So please come for the transplant. So patient may be in any condition. Basically, optimization does not happen. So obviously, if there are direct contraindication for the transplant, we may not go ahead with the transplant. But optimization is an important part of doing the transplant. Then we get more stable recipients. And then acute liver failure, we just, in ALF cases, what we can do is we can just flag that we have a ALF person and we can request for a super urgent cadaveric donation. But you may not be so lucky that every time you can get a donor within that 2 to 3 days, because in ALF you may not get more than 3 days also, because of the cerebral edema, brain death can occur in ALF patients also. So in those cases, living donor liver transplant works like miracle, because you have a donor available easily in the family. Within 2 days, we can go ahead with the surgery. So what are the disadvantages? Basically, we add up a surgery on living person. So there is a operation involved in that, and there is going to be a morbidity and mortality as it is a surgery, but we try to keep it as low as possible. So what is living donor liver transplant? This is a donor liver who is a relative. So we take out commonly right lobe for the adult, because it is around 60 to 70%, and 30% is kept with the donor. So minimum 30% is required. If it is less than 30%, we do not accept the donor as a donor. So the second beautiful thing about the liver is the only organ in the body which regrows. So if this is 30%, after 8 to 12 weeks, it becomes more than 90%. So it again regrows. So that is the benefit of living donor liver transplantation. And this right lobe goes to the recipient, and this way we anastomose it. So for liver, it is not mandatory to do a HLA matching, a cross matching. Most important mandatory thing is a blood type compatibility. So the way we give blood, we can give the liver. So O can be given to O can be given to any other blood group also, and AB can take any other blood group liver also. But in case of cadaveric liver transplantation, the list for each blood grouping is so high that across the blood group donation cannot occur. So in cadaver, O goes to O only and A goes to A only. But in living donor, if somebody from the family is O, he can donate to the recipient if he is A also. So how do we select the donor? Basically, there are a few important criteria. Patient should be between 18 to 55 years of age. There should not be any major comorbidities, anything like uncontrolled hypertension or diabetes, negative for serology, HIV, HbSg, HCV, then compatibility of blood group, no HLA matching, normal liver function has to be there, and there should not be any major abdominal surgery or history of any malignancy in the past. So if these things are matched, and there should not be any addiction, or there should not be any drug abuse, and mentally he should be well and sound. So for all donors, we have to do a psychiatric clearance that patient is mentally sound and willing to go ahead with the liver transplant. So after this basic criteria is matched, Then we have a stringent criteria of 4 phase workup. So 4 stage workup we do. First stage, we do a basic blood test and sonography. Second, we do a CT volumetry. So in basic blood test, we just do a CBC, RFT, LFT, PTNR, and HbA1c, lipid profiles. Then we do a sonography in which we see how is the fatty liver grade 1, grade 2, or if there is any major anomaly or any issue. Then we do a CT. If the stage 1 is cleared, stage 1 is good, then we go ahead with the CT volumetry. CT volumetry, we do a proper measurement of the volumes. So what would be the total volume of the liver? Then right lobe would be around 60-65%, or how much would be the right lobe volume? How much would be the left lobe volume? And how much would be the remnant volume? So once we do that, and once we are okay that okay, liver attenuation index is good, the volumetry is good, then we give them clearance for the stage 3. In that we do MRCP and other imaging methods, where we do a duct, you see the ductal anatomies, and then advanced workup. So in advanced workup, there is 2D echo, other endocrinological workup, metabolic workup. All those workup we do in which there can be a hidden liver disease or any other hidden major issues, including G6PD also we do. So once the whole workup is done along with all the cardiac evaluation, then the committee occurs. So in committee, there should be a clearance. And once the committee gives approval for this donation from a relative to the recipient, then transplant can be done after that. So you can see that there are multiple issues which can be involved in donor surgery also. So the important challenge which we get is that we have to keep the morbidity obviously and a mortality absolutely low, as much as 0%. So the imaging which we do is a high-end imaging, where you can see that these are the different arterial anatomies. You can see, so this is right hepatic artery, segment 4 artery. This is left hepatic artery. This is cystic artery. And then this is actually a classical arterial anatomy, but you may not get this anatomy every time. So this segment 4 artery sometimes gives us trouble. So if we are taking right lobe, that means we are not going to take segment 4. So in that case, if it is coming from the right hepatic artery, we have to save it. So in this case, we have to cut the right hepatic artery here. Okay. So if this segment 4 artery comes here, then we have to give cut here, so that we get very small stump. So it depends from where the segment 4 artery arises. If the segment 4 artery arises from this side, from the left hepatic, which is a common scenario, then the arterial mobilization is not that difficult or not that challenging. Similarly, when we do a donor hepatectomy, we see the portal anatomy. So this is right portal vein, this is left portal vein, and this is main portal vein. So in this case, we can transact the portal vein here. So you can get a single nice portal vein. This is all the classical anatomy. But sometimes if this branching arises from here, so if you consider that the left portal vein is coming from here, then it is difficult that you can't clamp here, because left portal vein is also going to go in this case. So in that case, you have to clamp here and cut the portal vein here and then here. So then you will get 2 portal veins for anastomosis. So these are also some challenges which we face. Then hepatic venous anatomy. So as we know, there are 3 major hepatic veins which drain the liver into the IVC. So this is right hepatic vein, this is right, this is middle hepatic vein, and this is left hepatic vein. So in this case, normally right hepatic vein we cut here. So this is the transaction line where we cut the right hepatic vein, and our transaction line comes in this direction. So when we take right lobe, it is transacted here. So you can see that segment 4, this is segment 4B and segment 4A. These also can get compromised in donor. So what we have to do, we have to cut here. So this one hole is there, and we have to cut here. This is the other hole. So we have to do an anastomosis or put a graft here, so that these 2 openings are joined, and then this is joined to the right hepatic vein. So there is a graft which we keep here that is connecting to all these 3 openings. So this is commonly we put a PTFE graft. So these are some technical intraoperative challenges. In MRCP, we see that how many ducts we can get. So this is one of the picture from our donor. So this is right hepatic duct, this is left hepatic duct. So you can see that right anterior posterior duct is going here. So if we cut here, we will get 1 duct. But if we cut here, then you might get 2 different ducts. So you'll have to do 2 different biliary anastomosis. So we have to think properly, we have to plan properly, and then intraoperatively also we do a cholangiogram and do the transaction. So during transplant, there are some important techniques. One is explant, as I told you that the liver which is not good, that has to be explanted. Second is retrieval, that the good liver from a brain dead patient or a living donor liver patient donor, we have to retrieve it and then implant it into the recipient. So there are multiple challenges in the anesthetic management also. Dr. Manoj has given good insight about some of the important topics. I'll just go through a few important points. One is induction. So sometimes induction also patient might get arrest. Patient might have too much hypotension. So that has to be done properly. We normally, whenever we do a transplant, we put major important lines like central line, arterial line, two arterial lines. Then we commonly do a esophageal echocardiography also during the transplantation. Blood products, when we take the patient for transplant, we still reserve 10 cryo, 10 PRC, 10 FFPs, 10 PCVs. We are trying to minimize it. So few last transplant we have done without single transfusion also, but in some cases you might require 1 or 2 transfusions. So overall transfusion during the transplant has gone down to as much as 3 to 4 PCVs as compared to the initial days transplant. So whenever it was done in 1964, 1968, in that time, one of the patient required 252 blood transfusions. So that was the amount of blood transfused during that transplant surgery. But nowadays it is 1 to 3, sometimes without any without any blood transfusion. So whenever we do clamping with a portal vein or a IVC, there are multiple hemodynamic changes. The heart rate goes up, the systemic vascular resistance increases. There may be a sudden hypotension. Patient may not tolerate the clamp, and you have to release the clamp. A sudden cardiac arrest can also happen. That mainly can happen with the reperfusion injury. So whenever we put the lever and we release the clamp, basically there are multiple products. Maybe because of a potassium related injury, there can be a cardiac arrest, which is also called a reperfusion injury. So as I told that this is a common scenario which we face, that the patient which is on the transplant table has nearly about 15 to 16 liters of ascites in his abdomen. So this is a major challenge. What we expect that if the patient presents earlier to us or referred earlier to us, the outcome would be far better, and the patient goes normally day 5, day 6 home. But if more the delay, the more are the going to be the problems and the hospital stay. So this is definitely an important challenge which we face, and we have to the solution for this is going to be an awareness that the transplant is not that difficult and not that costly as it was thought, and the outcome is wonderful. So basically, brief things what we do during the transplant. Once we open the abdomen, we see such kind of things. So this is liver, you can see this is spleen. So always there is a splenomegaly because of the liver cirrhosis. This you can see, this is a collateral. So these are very thin collateral. So if small injury to it, they bleed like a waterfall. So they have to be tackled very carefully. So most of the times people ask us that isn't it a difficult surgery or in portal hypertension, we normally don't do any surgery, then how do you do transplant? But undoubtedly, if you have to take out the liver, you have to do a surgery around the portal vein. We have to isolate the portal vein. So this is left portal vein, right portal vein, main portal vein. So it is definitely difficult, but it is achievable and we can be done with the good outcomes. And as we grow more, as we do more and more transplants, the outcome is definitely far better. So once we take out the liver, this you can see, this is called a piggyback technique, in which this is right hepatic vein, left hepatic vein. This is portal vein, which is anastomosed to the IVC. This is called portovenous shunt. When we expect that there is longer duration for the implantation, this is done. But nowadays it is not done so commonly. So you can see a beautiful IVC here. So this is the cadaveric, this is the recipient's liver, which is a cirrhotic liver you can see here, and a cadaveric beautiful liver which is implanted into a donor. So whenever we do donor right hepatectomy, as I told you, there are multiple challenges which we face. That one of them is doing a proper hilar dissection. So this is right portal vein here. So as I told you, the right portal vein, once we isolate it, we can transact it here. You can see this is a cystic duct, and this is infant feeding tube which is inserted into the cystic duct when we do a cholangiogram. So intraoperative cholangiogram we do, and this is a right hepatic artery which is going from here. So this is intraoperative cholangiogram. You can see that this is not so easy and simple cholangiogram. So if incidentally also you cut here, you are going to get 1, 2, 3 ducts, and you will have to do 3 anastomosis. So by any means, anywhere you cut, you are going to get 2 ducts. So this right posterior and right anterior, the 2 ducts are going to be there, but left duct we have to preserve. So the most important thing is avoidance of injury to the left hepatic duct, and take as much as minimum duct as possible. So in this case, obviously you are going to get 2 ducts, one here and one here, and then we clamp it here. So this is a marker pin which we keep, that where we should do a transaction. So this is during the surgery. Very meticulously we do it with trying to minimize very less blood transfusion, or without blood transfusion. So last many of the donors we have done without a single blood transfusions. This is a middle hepatic vein, which is along with that we have done a transaction. So normally MHV can be kept with the donors also, but it can be kept with the recipient depending upon the morphology and anatomy. So once the transaction is complete from anterior to posterior, you can see, so in this case, the middle hepatic vein is kept with the left lobe, that is with the donor. You can see this is the IVC here, and this is middle hepatic vein which goes into the IVC, and this is the transaction line. So once we do that complete transaction, we again do a completion cholangiogram. So this is a small video of mine where you'll just get a brief idea how things are there during the surgery. So this is a surgery of living donor liver transplant, in which we are going to take a right lobe. So right lobe, right donor hepatectomy is the surgery. So you can see I'm a lefty person, so I'm using the cautery with the left hand. This we normally do the marking of the transaction. So this is 4A, this is 4A, this is 4B, segment 2 and 3, and these are the other segments. So in this instrument which is used is a hydrojet. We use the water jet to dissect the liver, and every small pedicle, small line or small venous branch, we have to clip ligate. So undoubtedly it takes time, but over the time the total timing of operation has also come down, but it has to be done meticulously to avoid the post-operative morbidity. So you can see that after that we do a donor right duct, hepatic duct transaction. So hepatic duct is transected. Then this is right hepatic artery. So the right hepatic artery is already isolated, but we ligate it at the end of the surgery. So just before taking out the graft. So here we normally use a 30 Pro silk to tie it and then cut here. So we should get at least a small stump to do an anastomosis in the recipient. And then you can see the right portal vein is there here. So once we transect the right hepatic artery, then we clamp the right portal vein. So you can see this right hepatic artery is being ligated and cut. So sometimes this is another challenge, that you may get a very big portal vein, inferior hepatic vein. So this is an inferior hepatic vein. So if it is there, we have to anastomosis it into the recipient also. So it can be anastomosed to the recipient IVC, but it cannot be sacrificed. So here you can see that this inferior hepatic vein is ligated, clamped, and then cut. So that also comes from the IVC. It drains into IVC. So now right portal vein is being clamped. You can see. So after putting a proper, so there the clamping side should also be towards the right lobe to avoid a compromise of the left portal vein. So after doing that, we put a clamp in the right portal vein. So this is right portal vein, and this right hepatic vein. So once we clamp the right hepatic vein, we do not clamp anything towards the donor side. So that's why you can see that there is no clamp applied here, but just towards the body side we have applied, but donor liver side we have not applied any clamp. And now we transact it, and whatever blood which is inside the liver, that anyways it has to be flushed out. So once we take it out, we flush it with the STK solution or custodial solution. So after cutting so clamping pattern is also vitally important. So at any cost, you have to clamp portal vein first, followed by right hepatic vein. Because if you clamp right hepatic vein first, there would be a congestion and liver may go on swelling. So right portal vein has to be clamped first. Then we take out the graft. Then you can measure. Normally we measure the graft. What is the weight of the graft? And then this stumps are ligated or sutured. So then backbench, once we take out the liver, there are multiple things we have to do. As I told you, then we need to put a middle hepatic venue, middle hepatic vein we have to form, and then this is after putting a middle hepatic vein. This is a PTFE graft for the segment 5 and segment 8, and then it is attached to the right hepatic vein and to the IVC. So this is a beautiful right lobe graft which is implanted. In this also we did not do any blood transfusion during the hepatectomy. So this is an implantation. So you can see there are multiple challenges, intraoperative, preoperative, and few are the post transplant challenges also. Actually, every challenge can have a lecture of 1 hour. So we are just doing a brief overview of things so that you'll know that what is the procedure of the transplant, what are the problems or challenges which can occur during the transplant. So after doing the transplant, immediately there are a few issues which are immediate post-operative issues. So one, we have to give a immunosuppression because liver can get rejected. So immunosuppression has to be optimum. We normally use triple immunosuppression, which is steroid, then mycophenolate mofetil, and tacrolimus. So depending upon the side effect, we use other medicines. Then there can be a leak, which can be a biliary leak or any anastomotic leak. So there can be a bleeding infection, or there can be a thrombus. So this is also most dreaded complication. So we have to use anticoagulant with the due risk of bleeding also. But we err more on the side of a bleeding rather than a thrombus, because thrombus has a more morbidity. And then acute rejection. So in spite of that, patient may have acute rejection, but all these chances or complications are very minimal nowadays. So success rate is gone more than 90%, which is very good for the liver transplant for such a major surgery. Then regarding delayed issues, delayed challenges, one is the drug compliance. Once the patient is better, he's off the other medicines, only on immunosuppression, he feels that okay, आता मला काही गरज नाही आहे औषध घेण्याची, ठीक आहे, I'm good. And sometimes he misses some medicines. So those medicines which are for immunosuppression, which may be 1 or 2 medicine, they have to be taken lifelong. So but the compliance sometimes is not good, and then you might land up in rejection or other issue. Second is investigation. So initially you have to do investigation quite frequently. So when the transplant is done, initially we do twice a day testing. So in a day we do 2 double testing. Then once patient is getting discharged, so normally day of discharge is around day 5, day 6. Then when the patient is at home, then the investigation is weekly once or weekly twice. So initially weekly twice, once the 1 month is over, then weekly once, and then monthly it is done. So after 1 year, only 3 monthly blood tests has to be done. So we are trying to delay it as much as possible, but definitely it cannot come at the cost of the side effects or issues. So long-term things we have to consider, that patient has to be compliant for the all medicines and has to be compliant for the proper follow. And there are we can see many examples which the transplant which is done 10 to 15 years ago, they are doing very good, doing all routine their work, they are doing marathons. So basically there are the things which there are multiple challenges, but there is a solution for challenge also, and we are obviously trying to evolve from that. We are trying to make solutions for it, but the thing which is the support required, it is mainly from the patient family, the primary physician, and total transplant team. So once the patient is done, normally we obviously follow the fast track surgery. The average day of discharge, as I told you, is day 5, day 6. Frequent blood tests, as I told you, we do it. Then initially there are 7 to 10 medicines which may involve calcium, magnesium, bicosuls, and other things. But once the initial period is over, there are very few medicines. And for liver donors, the one who is donated from the family, living donor liver transplant, there is no lifelong follow-up or no medicine lifelong to be taken. So the one other important point is ALF. So actually for ALF also it has so many challenges that it will become a major topic for it. But I'll just have to want to just give you an example of this patient. So he is Bhuvan, his age is 6 years, and he came with us with a bilirubin of 43 and encephalopathy, grade 4 coma. And he was advised. Actually, it was an acute presentation of Wilson's disease, but his INR was 7.5. He was fitting the criteria for acute liver failure, and he was listed for a super urgent listing.
Liver transplantच आहे ना sir.
And he came out well after, maybe he was discharged. So during the surgery also he was arrested 3 times, and he was revived, and then he came back and he got discharged on day 6, day 7. So maybe ALF also, there are a few points like urgent evaluation, urgent donation. You may not get a cadaveric liver all the time, so from the family, and then raising fund within few days, within few hours becomes a challenge. So these are the brief things about the challenges in liver transplant. I hope if you have any issues or any points, any questions, you can reach us to the mail or any call. Thank you, sir. Thank you very much.
Sir, I think there is only one question in the chat box, that is about the expenditure for the surgery. But I know Dr. Vipin Vibhute sir is going to speak on availability and affordability of this liver surgeries. So I thank you very much for explaining us the pre-transplant, during transplant, and post-transplant challenges that we face. Now I request our President, Dr. B.L. Deshmukh sir, to felicitate Dr. Dinesh Zirpe sir. Sir, please.
Sir, this is IMA Upurna for you.
Thank you, sir. Thank you. Thank you.
Sir, bouquet for you.
Thank you, sir. Thank you.
And this is our financial diary for this year. So you can keep it on your table.
Yes.
We'll be arranging to send it.
Yes, yes.
Yes, thank you, sir. Thank you very much. Now, for the next lecture on pancreatic transplant, we have noted endocrinologist Dr. Uday Phadke sir. Dr. Uday Phadke sir is MBBS from BJ Medical College, Pune. He stood first in medicine and third overall in Pune University. He is MD from BJ Medical College. He is DNB and DM Endocrinology from KM Hospital, Mumbai. He is a fellow of American College of Endocrinology. He is conjoint teaching fellow at the University of Newcastle, Australia. He is awarded with the prestigious Srimati Bhandarkar Memorial Award for Academic Excellence and a special citation from the Mumbai University for securing the highest marks amongst all the super specialty candidates. He has worked as a lecturer in medicine and neurology at BJ Medical College and as a lecturer in endocrinology at KM Hospital, Mumbai. At present, he is practicing as a consultant in diabetes and endocrinology in Pune. Currently, he is director of endocrinology and diabetes for Sahyadri Group of Hospitals. He is a postgraduate guide for fellowship in diabetes under MUHS, involved as a faculty in more than 500 national and international symposia on diabetes and endocrinology. He has received Economic Times Inspiring Endocrinologist Award too, and moreover, he is a sportsman and a health freak. I welcome you, sir, and over to you for your topic, that is pancreatic transplant.
Thank you very much, sir. If you will just allow me to share my slides.
Can share.
Let him share.
Thank you, sir, for the kind words of introduction. I'm going to be a little brief because I want just a few basic principles of this important process to be taken across to the audience. The whole idea about pancreatic transplant is to restore pancreatic function, of which there are basically 2 types of pancreatic function. One, of course, is the very important function of insulin secretion, and glucagon secretion, which is happening from the endocrine pancreas, and the exocrine secretion, that is the digestive juices, which occurs from the non-islet cell mass of the pancreas. We have two kinds of basic pancreatic transplants available. The whole organ, that means the whole pancreas, is transplanted, or just the islet of Langerhans is transplanted, which basically means just the islet cells, which have the alpha and the beta cells secrete insulin glucagon. More often, especially in India, we do what is called the whole organ transplantation. There are three basic types of pancreatic transplants. One is called pancreatic transplant alone, that is called PTA. The other one is called SPK, which means simultaneous pancreas and kidney transplant, which is probably what is done most of the times. And there is something called pancreas after kidney. We have hardly any experience in pancreatic transplant alone. Most of the experience comes from SPK. And islet of Langerhans transplant is still experimental. It is done in research facilities, and I don't think we have the wherewithal to do islet cell transplantation currently. Now, what does a transplant do essentially, and particularly the pancreatic transplant? First and foremost, it eliminates the need for insulin. And you know that particularly in type 1 diabetes and insulin requiring type 2 diabetes, managing complex insulin regimens is difficult because insulin is now being secreted endogenously. A transplant reduces or eliminates dietary and activity restrictions due to diabetes. And very importantly, it decreases the severe low blood sugar reactions. You know that, even managing a high sugar is difficult. There is no doubt about it. But managing repeated hypoglycemias in which the patient just suddenly becomes unconscious or throws a fit or lands up into a coma can be an extremely distressing thing. And sometimes conventional methods of treatment are unable to rectify this. And a pancreatic transplant will help correct this completely. A transplant can also help manage the damage to other organs, particularly organs like kidneys, which is resulting from type 1 diabetes. So, improvement of blood sugars, arresting the progress of the complications of diabetes, and improving quality of life is the basic objective of pancreatic transplant. Now, as we were talking about the three basic types of pancreatic transplant, so who gets a pancreatic transplant alone? Sometimes a person who does not have renal failure, but who has extremely severe and debilitating variability in blood sugars may be a candidate for pancreatic transplant alone. But as I said, I do not have much experience of it. Whatever experience we have currently, most of it is on simultaneous pancreas and kidney transplant, which means that if you're doing a transplant for the kidney, you can also consider in that patient, if he's a diabetic, he or she is a diabetic, to consider a pancreatic transplantation. This is called SPK, or simultaneous pancreatic kidney. And sometimes you can do a pancreatic transplant after the donor kidney transplant. So the first problem was the kidney, and now you're facing problems with the pancreas, you can do it later. This is also not very commonly done in India. If you look at the benefit risk ratio, I've already shown you the benefits. Clearly improvement in quality of life, insulin independence, and lack of major fluctuations of ups and downs. But what are the risks? The risks are that there is need for major surgery, there is need for chronic immunosuppression, there can be loss of graft function. And in fact, the problem with the pancreas is that the loss of graft function is much more than what is seen with liver or kidney. So pancreatic transplant life is lesser than these other solid organs. There can be recurrence of autoimmune disease. We know that type 1 diabetes is autoimmune, and the same process may reoccur in the transplanted kidney because the autoimmunity cannot be changed. And of course, as Dr. Dinesh also said, some people just believe that after the transplant, they don't need to take any medicines. So they may stop immunosuppression and we can run into pharmacological non-compliance. But essentially, if you look at the benefit risk ratio, the benefits are far, far more than risk. Risk can be managed. We have already seen what the indications are, but essentially, indications for SPK simultaneous is diabetes and end-stage renal disease, GFR less than 20 ml per minute for dialysis when we are actually considering a kidney transplant. Pancreatic transplant alone, as I said, is only considered when the patient's renal function is very good, but he has extremely severe hypoglycemia unawareness or frequent hospital admission due to metabolic complications. That means either goes into severe hypo or lands up into decay, and we are unable to control him with conventional methods like insulin pump. So in these situations, one may consider a pancreatic transplant alone. There are certain absolute contraindications. And these are that if the patient has extremely severe coronary artery disease or very poor left ventricular function or very severe pulmonary disease, which essentially makes his life expectancy quite small, we don't consider a transplant. Active or past cancer without adequate remission is another absolute contraindication. A severe psychiatric disease with drug and alcohol abuse is not a good candidate for transplant, and morbid obesity, BMI more than 35. In any case, such patients are poor surgical risks anyway. Relative contraindications could be several, but they truly are relative. And if a patient genuinely needs a transplant in such a scenario, we might have to actually stabilize him before we consider transplant. So if he has peripheral vascular disease or cardiac disease or retinal hemorrhage or autonomic neuropathy or gastropathy, we will need to settle all these things before a transplant is even considered. Now, obviously, in any surgical procedure, we consider the risk to benefit ratio. And I've already said what the risks are and what the benefits are. We need to carefully weigh them. Make sure that there is a complete examination of the cardiovascular system, the neurological system, ophthalmological evaluation, basically for retinal status, metabolic status in terms of lipids, in terms of so many other things, and of course, renal function testing so that we know how the kidneys are functioning. I am not a surgeon and I cannot explain all this, but let me tell you that there are two basic things which are done. One is that the transplanted organ is placed side by side the kidney in the pelvis. And there are two types. So that's how the pancreas is fitted. And there are two ways in which the exocrine drainage can be done. One could be into the duodenum, or one is into the urinary bladder. The logic in urinary bladder is that we can use urinary amylase to look for graft function. So that's the surgical technique. What about the survival? Now, there are two types of survivals that we look for when we are talking about transplants. One is patient survival, and the patient survival actually is pretty good. If you look at the patient survival rates, let's look mostly for simultaneous pancreas kidney, because that is what is done most of the times. It's 96 to 99% at 1 year, 89 to 91% at 5 years, and almost 80% at 10 years, which is very good, I feel, on par with many other transplanted patients. This is actual patient survival. But what about graft survival? And graft survival for simultaneous kidney pancreatic transplants, there could be an immediate rejection in up to 10% of patients within 90 days. And this is usually because of surgical complications. And 5-year survival for simultaneous pancreas kidney is almost 73%, not bad at all. So in fact, you will see that if you're doing a simultaneous pancreas kidney transplantation, the patient from being an extremely ill patient, both because of fluctuating diabetes and also severe kidney disease, has a completely new lease of life and will be insulin independent, will have a normal renal function, 73% at least till 5 years. And I said, even 10 years survival, a 10-year graph survival, of course, it's not 73%, it goes down, but it's still there. So patient clearly gets between half to 1 decade of a very good life. And then even if he does require medicines for controlling diabetes, you still have a good kidney. And if you maintain his diabetes well, he will have a good life. Now, what about graft survival? How do we classify graft survival? Optimal graft function means A1C less than 6.5 without any therapy required for diabetes. Good graft function means A1C less than 7. He could require some drugs. He could even require some insulin, but the quantity of insulin is quite small, less than 0.5 units per kg per day. In marginal graft function, the A1C is more than 7, and there is insulin requirement, but at least it's manageable. It's less than 50% of what the patient required earlier. And a failed graft means there is absolutely no pancreatic function at all. There are several complications which could occur after pancreatic transplant. One, of course, is the surgical complications, and then, of course, a graft loss because of immunological failure, which I said will occur a little delayed. But the early complication or the early loss of graft is typically due to surgical complication. Now, typically, a pancreas, every graft, of course, whether it's liver, heart, kidney, is susceptible to complication, but particularly with pancreas, it's more predisposed to thrombosis, more predisposed to inflammation, and more predisposed to the complications of leaks and infections and high risk of bleeding after reperfusion. So these are the different complications that could occur after a pancreatic transplantation, and I'm sure Dr. Vibhute and Dr. Dinesh will be able to answer these things better. But ultimately, a successful pancreatic transplantation will not only improve the life quality of the patient, which has become extremely poor in a complicated diabetes, but it will also reduce recurrent and de novo diabetic nephropathy. It will improve peripheral and autonomic diabetic neuropathy. So there is a reduction in risk of sudden cardiac death. Some improvement in diabetic retinopathy is known. There is an improvement in the lipids. And overall, as I said, the quality of life is markedly better. To minimize surgical complications, the donors also have to be selected well. So they should not be extremely obese. Younger, the better. There is this expected cold ischemia time. Again, lower, the better. The liver enzymes should not be extremely high. The pancreatic enzymes should not be extremely high. And the patient, the donor, should not have other clinical risk factors like severe arterial hypertension, smoking, alcoholism, or history of pancreatitis. So obviously, healthier the donor, younger the donor, the result is going to be much better. Surgical complications can be minimized in the post-operative rooms by continuous nasogastric suction, IV fluids, intravenous insulin as and when required. And we can monitor for acute rejection by looking at creatinine for the kidney, amylase for the pancreas, decrease in urinary amylase in patients with bladder drainage, as I said, because if the amylase is going down, it means that the exocrine function is going down. And of course, in the later stages, you can monitor C-peptide and serum glucose levels to find out. The immunosuppression that is used for pancreas is now similar. The basic mechanisms and the basic idea of planning immunosuppression is now common to the solid organ transplants. But essentially, there could be induction therapy with monoclonal or polyclonal anti-T cell antibodies at the time of surgery. And maintenance is through a calcineurin inhibitor and an antimetabolite. That means a cyclosporin or tacrolimus along with mycophenolate. A lot of centers are avoiding or minimizing glucocorticoids in the long run, because this is clearly known to improve the graft. And of course, prophylactic treatments like antithrombotic treatments, antimicrobial prophylaxis is clearly important. The islet of Langerhans transplant is now currently done experimentally for both type 1 diabetes and chronic pancreatitis. But essentially, what islet cell transplant means is that we really don't transplant the whole organ, but take away the organ, isolate the islets through collagenase digestion, we purify them through centrifugation, and then they are infused by gravity through a cannula. Typically, they are left in the portal venous system so that they go and settle into the liver. The benefit is that there is improved glucose control, there is prevention of hypoglycemia, and insulin levels are increased and maintained so that euglycemia is maintained. Of course, there are several problems and risks. And what about the rate of independence from insulin at 5 years? You will see that clearly it's less than what we saw for whole organ transplantation. But here, what we are seeing here, this 30% is after a single islet cell transplantation. The focus is now changing, and there are many things which could be important in improving the results from islet cell transplantation. So we could have multiple islet cell donors, that we can keep replenishing these islet cells, not just once, but say maybe every year. We could have alternative islet sources. So we could have human pancreatic islets from cadavers. We could even have uh, the islets made from stem cell treatments, but unfortunately, these are not necessarily successful as of now. Xenotransplantation, that means using islet cells from other mammals, can be tried, like pigs, monkeys. Again, this is entirely experimental. We have no clear success or recommendations on the same. Microencapsulation is something in which the islets are put inside a bubble over which there is a capsule. So insulin and glucose, the flow is bidirectional. So glucose can flow in and insulin can flow out, but antibodies do not have access to the islet cell because they are blocked by the film there. So type 1 diabetics who are given these kind of microencapsulated islets will not have the problem of the autoimmunity destroying their islets. However, this microencapsulation is also experimental. We are also experimenting on less toxic immunosuppressive regimens, and all this is in research. We can also now be considering islet cell transplantation after chronic pancreatitis. And here, the advantage is that when there is some amount of tissue in the pancreas left after pancreatitis, you take the patient's own islet cells and do what is called a auto transplantation. So at least the insulin secretion part will be well maintained. And you know that after repeated attacks of pancreatitis, the complete endocrine and exocrine function is lost. Here, if we can harvest the islet cells before all things are lost, we could make sure that at least the diabetes part could be prevented and metabolic outcomes will be better. So the take-home message for today, we know that the goal of transplantation is to improve quality of life, to maintain and induce euglycemia, and arrest the progression of the complications of diabetes. Transplant is considered only in patients with serious progressive complications of diabetes, in whom the quality of life is unacceptable. And the expected benefits clearly are what I discussed earlier: marked improvement in survival, marked improvement in quality of life, no hospital admissions for severe lows and highs, and a clearly improved complications in terms of kidney, heart, nerves, and eye survival. Thank you very much for making me a part of this brilliant symposium, and it was a pleasure being here. Thank you very much.
Thank you, sir. Thank you, sir. Thank you very much for your excellent and elaborate presentation on pancreas. transplant with excellent take-home messages. Special thanks to you, sir, for taking this session in spite of personal hurdles. This makes you a great teacher of medicine. Thank you very much, sir. Now I request our President B.L. Deshmukh, sir, to felicitate you, sir.
Sir, this is IMA Upparne for you.
I humbly accept it, sir. Thank you.
Sir, a bouquet.
Thank you, sir.
This is a table diary, our financial diary for this year IMA. It's very useful, sir.
Thank you very much.
सर परवा तुम्हाला 2 डायऱ्या देऊन गेलो.
हो हो सर, माझी आपली भेट नाही झाली त्या दिवशी, पण आपण परत भेटू. आणि अभिनंदन तुम्ही प्रेसिडेंट झाल्याबद्दल.
थँक्यू थँक्यू.
Thank you, sir. Thank you. Now I request Alka Shirsagar madam to introduce our next speaker.
Yes. After listening to our Dr. Dinesh Jirpe sir on challenges in liver transplantation surgery and Dr. Uday Phadke on pancreatic transplant. So let us have a practical approach. So we have a talk by Dr. Bipin Vibhute sir on liver transplantation, whether is it accessible, available and affordable in today's era. So I will introduce Dr. Bipin Vibhute. He is a program director in Center for Organ Transplant, Sahyadri Hospitals, Pune, Nashik and Karad. See, today we are having many people, all of them are from very, very different parts of Maharashtra. So he is born at small village, Madgule, Atpadi, Sangli. So he has completed his education at prestigious institutes at Chennai, Kerala and Kolhapur. He has started his transplant career at Apollo Hospital, where he worked for almost 7 years. He was a part of team for almost 700 plus transplants, which included liver, kidney, pancreas and small bowel transplants. He came back to Maharashtra and joined Sahyadri Hospitals in 2016, where he started organ transplant program at Sahyadri Super Speciality Hospital, Deccan Gymkhana. Presently, it is a third largest organ transplant center in India, awarded by NOTO, National Organ Tissue and Transplant Organization, Delhi. The center has performed more than 180 liver transplants and maximum simultaneous kidney pancreas transplants at Sahyadri hospitals in less than 3 years. It's a real achievement. He is famous for his outstanding surgical skills, great patient rapport, and down-to-earth nature and an infectious smile. He presently is expanding his transplant program all over Maharashtra with the motto of providing organ transplants to every corner of Maharashtra at an affordable cost and at accessible destination. He has received Youth Icon of Pune Award from Times of India in 2018 and Best Organ Transplant Hospital in Maharashtra by Navabharat Award in 2018. He's got a Guinness World Record of maximum organ donation pledge in 8 hours in August 2018 and a London World Book Record in February 2019. Icon of Health Award in 2018. Record of smallest baby of 7 months to oldest recipient of 71 years successfully transplanted in Pune. First to start free liver transplant in India for pediatric patients age up to 12 years and EMI for liver transplant patients. Good sir, very social approach. Highest simultaneous kidney pancreas transplantation in Maharashtra, and his achievements are unparalleled, and that too at such young age of 39. So over to Dr. Bipin Vibhute sir. Sir, we are very obliged to start. Please sir. Sir, you can start, sir. Sir, you can unmute yourself. Yes, yes, sir.
Yes. Thank you for kind introduction, ma'am. I hope I am audible and my slides are visible.
Yes, sir, you can start.
Am I audible?
Yes, sir, audible, and we can see your slides also, sir.
Okay. So thank you, IMA, for giving us the opportunity to highlight about the transplant. And I am batting in a slog over. Basically, everybody is hungry and
But it's very
uh,
practical approach.
yeah, wants to be finished as early as we can. So I changed topic little bit. I'm going to cover affordable, accessible, because this has been given in the last IMA lecture. So I changed a little bit of title, but I'll cover all the aspects of the transplantation. And as I said, bowling and batting both difficult in slog over. So I will try to prove it. So I always start with Ganesha's slide and how this first transplant has been done in the globe. I'm not repeating the history, but everybody knows, and we pray Ganesha and Shiva before and after transplantation as well. सो जे प्रत्यक्ष महादेवाला हे शक्य झालं नाही ते अवयवदानाने शक्य केलं. सो स्टील ऑर्गन डोनेशन होल्ड्स लॉट ऑफ इम्पॉर्टन्स इन ट्रान्सप्लांटेशन. So we talk about the liver disease. I think since morning we are talking about liver disease, how to do transplantation, and many things. So I'm not going into the detail. I'm just going to be a very practical approach what you and me face during the OPD hours or whatever. So I hope everybody knows this man. He invented the first phone in the world, Martin Cooper in the Motorola lab. So uh, the weight of this phone was around 3 kg, and it was just lasting 5 minutes, and the modern phones were 15 minutes during his tenure. But now, one second, I'll just reduce my window. So now smartphones are definitely had changed over a period of 20-30 years, 50 years, and this is how a phone looks like now. So exactly the transplant scenario has also been changed. First liver transplant is done by Thomas Tarzan in 1963. It was an unsuccessful attempt, obviously, like a Martin Cooper. But after that, many more transplants are happening. And what been his biography says, whenever he used to start his transplant, the um, blood banks around the 300 kilometers used to be on their top, because they require lots and lots of blood transfusion during the, and a lot recoveries in the days and weeks in the ICU. But now things have completely changed. We do the transplant with just couple of one assistant, one nurse. A patient get discharged on day 4. Like what progressed like a smartphone, it has exactly, we have progressed in the transplantation as well. How I'm going to talk on it soon. So life before transplantation, how to measure the life before transplantation? So one is the quality of life, another is the personal care, whether they could manage their personal things or not, their family commitment, their professional commitment, and physical and mental stress. This is how we judge the quality or life before transplantation. So if you look at the liver disease symptoms and signs before transplantation, or any liver disease patient, any decompensated liver disease patient, so they will have stomach pain, lot of fatigability, because this is one of my favorite symptom or sign, whatever you say. Fatigability is the first sign you get it in the liver disease, and subsequently jaundice, weight gain or weight loss, bleeding, and vomiting. And because of that, patient has to suffer a lot. Look at this. These are just 2 months before this patient was going to the office, and suddenly he developed ascites, required tapping twice or thrice a month, need to get admit, repeated tappings, and a lot of other problems. Like a GI bleeding, decompensated, there is the incidence of around 15% patient, they will have a GI bleeding. If you are at a remote place, whether there is endoscopies or nearby hospitals are not accessible, then mortality is very high. Weight gain, weight loss is also a problem because of fluid retention. You get a vein due to muscle loss. If you there will be a lot of weight loss, and subsequent hamper the quality of life as well. Food restrictions, as not like before the liver disease, you can carry on. Definitely you cannot have any even drop of alcohol. You cannot or you preferably avoid the fatty foods, junk foods. and definitely raw and uncooked foods because of I'm not going to detail about this diet, but sometimes patient will have persistent abdominal pain, maybe because of ascites, SBP, and many things. Stress is the another factor because there are many more papers which suggest that liver cirrhosis, in decompensated liver cirrhosis, there is a lot of family and personal pressure, stress on it. So I have one of this paper or study. If you are in child A, then your quality of life is a 10% decrease as compared to before the liver disease. And if you are child B, it is around 20 to 30%, and child C is 80%. But in our scenario, I will say it is around 90% because of many things: financial burden, family stress, physical stress, inaccessible hospital, expenses in the hospital, and a lot more things. So I'm not going to talk about when to refer for transplantation. This has already been spoken, but in single sentence, if I have to describe the indication of transplantation is if the function of the liver is inadequate to meet the requirement of the body, and if that lead to liver failure, then they require the transplantation. So I really don't go by the whatever indications are mentioned in the books, and if I strongly believe on this definition. So timing of transplantation is extremely important when you do, because Pollard hit the ball very hard, but sometimes it goes over the fence, sometimes he gets caught on the boundary or wherever. But Virat Kohli, most of the times, whenever he hit the ball, he times the ball well. So timing of the hitting the ball in the cricket or anywhere, even the driving, even a fraction of second, if you are late, your timing is not, you met in the accident. So timing is extremely important, and similarly in the liver transplantation also, timing is an key for the good success rate. So patient need to be fit enough to get transplantation before he become unfit or gets into the complication. So what transplant actually makes? So transplant makes complete makeover. How? So definitely there is a improvement in the quality of life. Practically there is no food restriction. Exercise, I will come to it on exercise, how our patient have done in last 3-4 years, and improved their professional careers. We allow them to carry on their jobs or businesses after 3 months after transplantation. If patients are sick before transplantation, then probably 6 months to 1 year, but they can definitely do the work near to transplantation. Almost 90% it will be near to normal life. I will just reserve that 10%. Why? I'm going to come back to it. So definitely there is a reduced rate of admissions. Expenses of medicines are there after transplantation, but they are definitely less than pre-transplantation. Whatever miracles we see in the field of transplantation or medical field, you need a uh, uh, mm, uh, prayers or blessings from the God. So I always strongly believe, because sometimes I feel this patient won't do good and they do extremely good. And I'm sure as a medical fraternity, all of us experience these things and wonder at the back of the mind, or when you go home, how these miracles happens. But yes, we have to believe in the God whenever you come across. So this is little stretch picture. So he has practically no muscle mass, huge ascites, repeated tappings, and this is the 1 month after transplantation. And this is what I was talking about, the exercise. So this man was on dialysis, ventilated. His sister gave the liver. He's from Satara, teacher by profession. And after 2 years after transplantation, he wanted, he's a housewife, farmer by occupation, and he wanted sister also to run and show to the world that after transplantation you can have a normal life. So in the lockdown, basically he completed 50 kilometers marathon on the teachers day. So this was the great achievement, and there are many more such examples. This patient is from Nagpur, had a lot of trouble before transplantation. He also ran the marathon. Then people have gone to the Himalayas. This is our patient from Mumbai, has written the book that second go on the her personal experience about the transplantation and how people treat and how they misguide about the transplantation. He's from Punjab, recently transplanted nearly about 1 year, almost about to burst abdomen. This is immediately after transplantation. I mean, 3 weeks after transplantation, and he came just follow up after 1 year, and he completely normal and doing job. So yeah, definitely new liver change the life after transplantation. But yes, you have to make sure that your brain and tongue is connected. But nowadays, because of availability of smartphones and gadgets, what you talk most of the time, we don't notice that they record, sometimes they shoot, so and they misinterpret a lot of things. So whenever we counsel this patients for any field, we have to be aware of it, that somebody is doing it, and we have to be always connected what we talk and what we think. So why Indian women have a red dots on their forehead, I'm not going to detail about it, but this is you can read it why actual reason. But another evidence sometimes they produce, because I have experienced during this lockdown or during this year, that many patients they record previous doctors recording, and they to show to you that whatever they have shown. So we have to be careful what we talk, otherwise you sometimes land up in a problem. So I'm not going into detail about the pancreas transplant, but we have completed 255 liver transplant and 14 pancreas transplant because of introduction. I think it was last year's data. And when I started in 2016, um, what I found that Indian people or Indian perspective, everybody wants good treatment, fast treatment, and cheap treatment, and this is the true, and this holds true for the each and every field. And most of the time, it is not possible. So most of the time, these transplants are driven by the financial constraint. So we have started EMI for transplantation, fundings as well. So I'm the member of a couple of transplant foundations, so to raise the funds. So this is the one thing. Second thing, there is lack of liver failure units. What does it mean? Before 2016, before we started the transplantation in Pune, there were very few liver failure units, but they were not dedicated. So this is first we started to correct it, have a dedicated unit. Still, we have 16 bedded, completely dedicated to liver patients unit at Sahyadri Deccan. Lot of false promises, because नाकात औषध टाकल्यानंतर कावीळ जाते, किंवा एक काढा खाल्ल्यानंतर, गळ्यात माळ घातल्यानंतर, असे lot of false promises people face, and they don't come forward on time. And once they exhaust all the resources, then they come to us, and this is why we actually face the financial constraint. So basically, there is a lack and fear in our medical fraternity also about the transplantation, about the success rate and cost of transplantation. I'm coming back to it also. And most of the people think this is the last ditch therapy with no other options. So I will leave this slide, but most of the time we try to do this Indian jugaad. So we tried, if somebody has ascites, we don't evaluate why there is ascites. Somebody level liver cirrhosis, so we give diuretics, we give albumin, lot of things, and we exhaust most of the money as well as the time, crucial time. I think I have evaluated almost, I have saved, in fact, almost 41 patients, those who have come for the transplantation and turn out to be different. So somebody turned out to be tuberculosis, a few people NCPFs, a few people EHPOs, and we have successfully treated them so far. But Indian jugaad is sometimes doesn't work. But yeah, people have a lot of fear about transplantation, and they insist to do it, and we compel to do that one. There is a lot of false promises about this case with Budd-Chiari syndrome. So treatment in initial stage is to put the tips, but unfortunately this patient has put a 1, 2, and 3 tips. This is up to the spleen. If you look at the spleen, how we are going to transplant her, because they said that this stent is going to be there for lifelong and you will be saved. So poor girl, they spend a lot of money, and now she requires transplantation. The results are poor after transplantation, because this is almost in the right atrium. So we have to put the heart. We have to do the lot of modification. This is not going to be usual transplant, but young girl, we have to give her a chance. So we are going to transplant her very soon. So this is coming back to the question I think somebody asked about the cost of transplantation. If you compare the cost of transplantation in decompensated chronic liver disease, it is close to 4 to 8 lakhs per year. That is includes frequent visits, blood products, frequent labs at least twice a month, minimum 2 admissions. I'm talking about minimum 2 admissions if they are stable, but they require more than that. Endoscopies at least once in a month, but nowadays because of aggressive management and fear of bleeding, we do almost once in a 3 months, frequent tapping and albumin. So if you compare this cost with the transplantation, transplant cost around 15 to 20 lakhs, because our intention to start the transplantation in Pune was to target the middle class, because if somebody is staying in a Taj or somebody is flying in a business class, they can go anywhere and get transplant done. Who cares for them? But there was a time when I started, transplant cost was 25 to 30 lakhs, and we started with the 15 lakhs, intending that we will help these middle class people and poor people. So cost today's is 15 to 20 lakhs, depends on the sickness of the patient, which includes everything: donor surgery, recipient surgery, medicine, ICU stay, and whatever till discharge, whatever they require. For low class people, we have started the transplant at Sassoon. We have successfully done the 4 transplants now with just an consumable cost around 3 to 4 lakhs. That also we can get the funds if they cannot afford. And with transplant, there is a 90% improvement in the quality of life, less doctor visits, no endoscopies practically, no albumin blood and blood products. But yeah, cost of medicine is 40 to 50 thousand per year. That I think that cost close to the, if you are diabetic, hypertension or thyroid, cost almost comes to that level. The problem is the what Albert Einstein says: ego is equal to 1 divided by knowledge. Few people, they don't know how transplant is done. Some in conference or somebody tells that transplant doesn't get successful, and they just tell the people that transplant is not your cup of tea. But they don't send, is there any option, can we save these people? Because if one member or head of the family, if they die because of the liver disease, whole family comes on the road. So I have seen many times and I feel very bad about it, but that is the truth, because this is what Indian scenario. When 1996, when transplant started, this is the there is only one or couple of centers and a lot of patients, so they used to choose the patients for transplantation. But now it is like a shark. So there are plenty of centers, almost 77 liver transplant centers across the India, and I'm sure it must have been increased now. And because of that, patient moves from one center to another center, and a lot of false promises, and finally they land up in a fish pond like this. Actual transplant, I think Dinesh explained. I'm not going to talk about the actual transplant, but yeah, as a surgeon and as a transplant hepatologist, we have to deal with the Maruti 800, BMW to Audi to Volvo to whatever you say. But we have all the gadgets to deal with. Every patient is the not same, and every transplant is the not same. So yeah, there are a lot of challenges about the transplantation, but yeah, we are capable enough to do, and almost all the centers, I think they fulfill the criteria. They need to get a license before transplantation and do. So most of the times this abdomen will be stuck like this. There are a lot of bleeding. Sometimes we have to pack it. Sometimes we get patients like this. This is the pre-transplant patient, not a post-transplant patient. We did tracheostomy. He was on ventilator, stabilized, and transplantation. And this is the 1 year after he's celebrating his birthday of the same day of transplantation, because most of the people, they change their birth date to the transplant because they think this is their rebirth. So they have chance to celebrate the birthday actually 2 times. So transplantation on time, if you do it, this is both the patient got discharged on day 4, and our average discharge time is still around 90%. Patient is day 5 to day 6, even for the living donor during transplants. Very sick patient, as I said, they don't do good. So referring on time is extremely important. So few last 4 5 slides, I'm just going to common myths and facts. Results are not good, results are extremely good with transplantation. I showed you the statistics about the cost and the quality of life before and after transplantation. So you need to be a little bold to take a decision, and we are not a god to save everybody, but we can do the in the maximum times. We as a group, we have a 91% success rate. We are in the rank with the world's best transplant centers. Cost, as I said, we have started 15 to 20 to 18 lakhs, depends on the sickness of the patient. Pediatric transplant, as ma'am said, we started doing the free transplant, but because of free, people used to come, and then they will have a lot of challenges post transplant to manage. So there will be no commitment from them. So we have started charging around 2.5 to 5 lakhs, at least some commitment from their part, and we need to know whether they truly want to save the kid. And if some genuine patient, if they don't have money, please refer to us. We will try to help them out. And as I said, and as Fadke sir said, about the pancreas transplant, we are the highest in the country currently for the pancreas transplant with good results. Cost around 15 lakhs, inclusive of all. Life is restricted after life. Yes, definitely not restricted. Quality of life improved by 90% as compared to before transplantation. Most of the patients, or most of the time, we think that post-transplant period or post-transplant care is difficult. But believe me, we have made it very simple. Early discharge, we give the home nurse for 4 or 5 days. They teach at the home how to take care at home, because that is extremely important. How to do lab, how to take medicines, how to eat, how to clean, everything they teach. And then they take care on their own, and we allow them to go out from the day of discharge, 1 hour in the morning and 1 hour in the evening for the exercise. Sit with the families, eat whatever healthy, homemade, prescribed diet by the dietitians. Definitely they can eat and drink outside the hotel after a certain period of time after transplantation and post-transplant medicine already explained. So as Dinesh mentioned, a lot of requires transplantation ICU stay. I'm not going into the detail, but yeah, we need to be on the top of it about the diet, personal exercise, care. We have a guide how to take care of their daily hygienes. And we are proud to say that we are first to transplant acute liver failure before they used to go to Chennai or Delhi. This girl we saved. This is 5 years now from transplantation. So we started, we think these are the miracles because her bilirubin was 58, INR was 8, we transplanted, and we thought that she will not survive, but she survived, and we did the flag hosting immediately next year from her. And this is the first patient I operated in Pune with a liver trauma. Now he's a father of one kid. And again, we did a flag hosting from him. And as we have a couple of books, Second Go, written by the Radhika Sachdev about her life story. Another is the last year published as the Journey Through a Liver Transplant, a True Story. It's available on Amazon and other bookstores. So transplant is a real challenge, and a lot of things, the way to go. Sky is the limit in the transplantation. No matter how beautiful you are, immune system looks at you in a different angle. So this is one of the challenge to manage immune response as well as the infection. As a transplant physician, it's tough job sometimes. So to end, I think we need to be very careful, because care for your head, not everyone gets a replacement like Ganesha. So thank you very much for pleasant listening. Don't be angry on me if I talk something which is not appropriate. because anger weakens your liver, and sometimes you may land up consulting me. So transplant is a new beginning. No matter how far we are always, our roots are connected. I'm always available on the phone or email. If any queries, I'm glad to answer. Thank you very much for pleasant listening, and thank you IMA for giving us opportunity for the whole team to express our thoughts.
Thank you, sir. There is a one question from Dr. Umarji, sir, that how is the functioning of artificial liver? Can you specify a few points?
Yeah. So artificial liver is only that concept is still there, but this is not very successful because liver carries around 500 functions.
Yes.
So it is not like one or two functions we can manage or we can control. So this is a temporary breach for the transplantation, and it is not an like other implants.
Yes.
Similarly, there is a xenotransplant that is also in a process, but that is not successful yet.
Thank you, sir. Thank you. Thank you, sir, for your wonderful lecture with very practical approach with life before and after transplantation, which is very important for transplantation surgery, for liver functioning. And there is a, just you said ki there is a decreased symptoms, so that is also very important because the patients are really dying with the all the difficult symptoms like bleeding and all. And sir, you have shown your all cricket slides in between, and your batting also was so nice, and with lovely Ganpati, Shiva and Sai Baba slides. So it shows that your thorough knowledge and dedication towards this transplant career, sir. Sir, all the best for your future career. And we all IMA, we thank all our so this hospital team. Sir, I will request Dr. B.L. Deshmukh to felicitate you.
Yes.
And Dr.
Sir, this is IMA Uparna for you.
Sir, thank you. खूप आभारी आहे.
Sir, and this is a bouquet. Thank you, sir.
And a financial diary for you, sir.
It's very important, sir. Thank
Yes.
you.
Okay, sir. Thank you, sir. Now, sir, at the outset, now I take this opportunity to thank all stalwart faculties for their excellent and informative talks in liver disease management and pancreatic transplant by Dr. Uday Phadke, sir. Entire Sahyadri Hospital team, I really thank for being a part of our webinar today. I thank DGC team for their technical support. Special thanks to Mr. Dipen sir and Mr. Siddharth Linge sir for giving us this all work the smooth. I thank our IMA staff with whose help we could arrange the webinar smoothly. So I declare that this webinar comes to end. Before that, I will thank our Dr. Thivsara sir, who is today's MMC observer, for attending our webinar and observing the webinar. Thank you everyone, and thank you. Now I say that this webinar comes to end. Thank you very much. Thank you all.